fix my hair. Going on TikTok as well, so you can follow me on TikTok at ThinkNursing. And one word. Did I share the live already? No. Let me share it up to all my wonderful folks out there from early. All right. Hi, Prince. What's up? How are you doing? Thank you for tuning in. Trying to make sure I come on early, very early. 5 minutes before the time. Yeah. Still early. What does it say to call now? Hello? Your timing is, I just started my live. Mm-hmm. All right. How are you guys doing? I'm trying to see. Who is on over by YT? If you don't mind just saying hi. All right, just type something in the chat. That would be nice. Oh, you mind? Well, hi, Samson. Thank you so much for tuning in. All right, remember to go ahead and top up the live. All right, just to say you're there. All right. You're from Australia? Okay. Brother Shaka, welcome. Yes, it's been a while. I haven't seen you on my... Oh, thank you for that, Heart Me. I haven't seen you on the live. Remember, go ahead and top up the live. Please, may I beg you to top up the live so other persons can know that the live is active and up and running. All right? So remember to do that. Yes, Samson, I'm from Jamaica. I'm from Jamaica. Have you been there? Yeah, let's top up the live. Get those numbers up in terms of the heart, you know, becoming red. Yeah. Hi, Roman. Welcome, welcome, welcome. How are you guys doing? How was your day? Or how is your week going so far? Thank you, Brother Shak, Bro Shak. Thank you for that. Thank you. All right, Dash, good morning to you too. It's actually night for me still, you know. It's 7 o'clock. Well, thank you, thank you. What time is it for you? Yeah, let's get the live, you know, let's get the live going. You can go ahead and, you know, remember your heart me's and remember your comments, your share. That's all we're asking for on the live. I'm not that needy. Very, very simple. The only thing we need is for you to tap the screen, share the live, and comment. That's how other persons get over to the page. All right, and if you're new here, my name is Stacy. You can follow me on YouTube at ThinkNursing. You can also follow me on TikTok at ThinkNursing as well. I share the longer form of the content that I post on YouTube or on TikTok on YouTube. So if you miss any of the live at any time, they're posted on YouTube at ThinkNursing. So you can go over there with your popcorn, your water, your drink, whatever it is, and get those content, you know, going. All right. Who is joining us for the first time? Hi, Champagne. 2 o'clock morning. Let's roll, like, and subscribe. Definitely. How is your workout regime? It's still going, you know. It's still going. I am doing 5:30 in the mornings at 5:30 in the mornings, Monday, Wednesdays, and Fridays. I'm doing the cycling. I still do my jump rope and, you know, just try to mix it up a bit. So that's it. Joy Williams, welcome. Thank you for the gift, champagne. All right. All right. Who is joining us for the first time on the page here? If you don't mind, just put a little heart or something in the comment section. Oh, 2-4. Okay. All right. Just put a little heart in the section if you're in the comment section if you're joining us for the first time. All right. So 7 o'clock on the dot. All right. Thank you, Marvin, for liking up the live and all of you guys. All right. Okay. Yeah, so we're doing the respiratory system today. Just in case you missed the live stream, we've done a few, you know, live streams for NCLEX Prep. And even if you're not doing the NCLEX, it still will help you because I'm still learning. Never too old to learn. So even if you're a nurse and you're passing through, it will help you as well. If you're studying for, you know, your RENR, which is the exam for the Caribbean, it will help you as well as, you know, the LPN. So it's a mixture. You'll get that information. All right. Shelly, welcome, welcome. Nice. How are you doing, Harry? Pitts. L means like. Totally understand. All right. Perfect accent. Look at wisdom. You are very inspiring. Thank you, Donna. Thank you for saying that. Thank you and welcome. All right. So, yes, that's what me figure more or less, Harry. All right. No negativity over here. All right. So the L means like. Thank you. All right. So what time now? 17. All right. So. All right, so I say 7:05, we can actually start. All right, yes, winner. We'll just give a few more persons the opportunity to pop in. But as I say, if you're new here, my name is Stacy. I'm originally from Jamaica. Transitioned here in 2016 as a registered nurse, emergency room nurse. I've been practicing since then. I went back to school, did my master's, working as a house call nurse practitioner now, and trying to become a content creator, you know, just helping other persons. So definitely, you know, stick around, go onto my YouTube page and subscribe. I talk a lot about my journey over there, so you can actually get to know me a little bit more and what my page is all about, why I'm doing this. All right, so definitely go over there and subscribe. And you know, if you have any questions, definitely go ahead and inbox me. I'm pretty transparent. So if you have any questions as an international nurse, I'm going to be your go-to person. All right. If you have any questions regarding the whole process, I did use a recruiting company. So feel free to go ahead and ask me any questions regarding that. And I will help answering as much as I can. All right. Liu Kang, I'm doing good. Jovi Vlogs, thank you so much. Remember to go ahead and tap up the live. This is the first time I see so much persons on the YouTube live and they're actually, you know, very active. I really like that. All right, so definitely go ahead and, you know, do that. All right, so let's get the questions. Pull up here. All right, let's get the questions pull up here. And as usual, we try to just look at the answers and see how best we can answer, you know, A, B, C, D. And then if we don't, you know, really understand, we'll try to explain each answer and see why probably that's not the best answer. All right, but the rule here is you have to save the patient. You have to answer something. All right, you have to answer something on the test. So you have to choose either A, B, C, or D in order to save the patient life. All right. And then the other thing is, remember, use your airway, breathing, circulation to answer your questions. And always think about the safety of the patient first whenever you're answering the questions as well. All right, so those are the guidance when it comes on to answering your NCLEX question. All right, so we will start off with some simple questions. All right, remember to go ahead and share up the live. All right, share up the live, do your daily heart means, and comment. All right. So we're gonna start with the first question here. A client with COPD is on 4 liters of oxygen via nasal cannula. All right, the nurse notes confusion and decreased respiratory rate. What should the nurse do first? So a patient with COPD is prescribed 4 liters of oxygen via nasal cannula. The nurse notes confusion and decreased respiratory rate. What should the nurse do first? A, increase oxygen to 6 liters via the nasal cannula. B, decrease the oxygen to 2 liters. C, place on non-rebreather mask. D, call the healthcare provider. So you have a patient that has COPD and the patient is on 4 liters of oxygen, but you notice that the patient is confused and the respiratory rate is decreased. What will you do first? A, increase oxygen to 6 liters. B, decrease the oxygen to 2 liters. C, place on non-rebreather mask. And D, call the healthcare provider. Champagne says D, which is called the healthcare provider. Sprinkle says B, okay, which is decrease the oxygen to 2 liters. And Carousel says B, decrease the oxygen to 2 liters. Why did you choose D to call the healthcare provider first, Champagne? Why did you choose that one? Remember, always think about things you can do at that time for the patient. All right, so what can you do in the meantime? What are you thinking? All right, just remember that this is a COPD. You have too much oxygen on board. That can cause problem because, they drive from, the hypoxia actually is what they drive on. So you just decrease the oxygen and hopefully that will help with, their symptoms as well. All right, so too much oxygen can suppress the hypoxic drive in COPD, leading to CO2 retention. So lower the oxygen and monitor the patient closely. All right, so if you notice that the patient is on the 4 liters, they're confused and they're having decreased respiratory rate, then definitely go ahead and decrease your oxygen level. All right, because that's what, your COPDs, they operate on low oxygen. All right. B, the patient with COPD doesn't need so much oxygen. Yes. All right, they don't need so much oxygen. All right, so what's a good oxygen saturation for this patient, a COPD? What's a good oxygen saturation rate for these patients? What is your goal? What the range you're looking for? There you go. Okay, what is the range you're looking for? Anywhere between like 88 and 90% is pretty good, and 92 is pretty good for your COPD patients. All right, which finding after thoracentesis requires immediate intervention? All right, which finding after thoracentesis requires immediate intervention? A, diminished breath sounds on one side. B, small amount of serosanguinous drainage. C, pain at the puncture site. Or D, oxygen saturation of 95%. So which finding after thoracentesis requires immediate intervention? A, diminish breath sounds on both sides. B, small amount of serosanguinous drainage. C, pain at the puncture side. D, oxygen saturation of 95%. All right, so A, definitely. All right, so A, what are you thinking about? If you have diminished breath sounds on one side, what are you thinking about, especially when it comes down to the thoracentesis? What are you thinking about? Lung collapse, okay. Yeah, so you're thinking about your lung collapse there with your thoracentesis. So definitely if you have your different diminished breath sounds on one side, your pneumothorax is what should be ringing in your ears, all right? That is what you're thinking about. All right, what are some of the signs and symptoms apart from your, diminished breath sounds there? What are other signs and symptoms you can, see here that will tell you that this patient is having a pneumothorax? What are you looking for? Yes, Shelly, the collapsed lungs. See, oxygen saturation is going to be low, okay? What if they're thinking about like your tension deviation, okay? Deviation on the affected side. All right, so you're thinking about your tension pneumothorax. Yes, why, Angel? Their oxygen saturation will become low. They'll become restless, definitely. All right, so that is what you're thinking about. One of the complications you're thinking about when you're doing thoracentesis. All right, Diego, I'm going block here, you see? All right, so definitely giving you one more chance. UTI, no, we're not thinking about UTI. All right. You're expecting a little bit of a pain at the puncture site. All right. The oxygen saturation, that's what you're aiming for, 95 and above. All right. So you want to make sure that their oxygen saturation is within that normal level. If it starts falling, if they're becoming hypoxic, then you can always think about something else. And the first thing that should be coming to your mind is, the pneumothorax, tension pneumothorax. All right. So absent diminished breath sounds suggest pneumothorax, which is a very serious complication. The chest tube becomes disconnected from your drainage system. What is the nurse's priority? So you have a chest tube that is in and it becomes dislodged, all right? Disconnected from the drainage system. What's the nurse's priority there? A, clamp the tube. B, place the tube in sterile water. C, call the provider. D, apply occlusive dressing. So you have a patient that has a chest tube in and then the tube becomes disconnected. What is your first nursing priority? What is it that you're going to be doing? A, clamp the tube. B, place the tube in sterile water. C, call the provider. Or D, apply occlusive dressing. All right, so Denise says A, clamp the tube. Champagne says D, apply occlusive dressing. Okay, anybody else? Anybody else with any answer? What about on YT here? John the Measurer says A. All right, so John the Measurer says A as well. Nobody says B, place the tube in sterile water. So placing the tube in sterile water is going to be the first priority. Yes, Shelly, that would be the priority. Placing the tube in sterile water. Why do you do that? You're trying to, because you remember, just think about it. If you have the tube disconnected, you're going to have to rush now to go ahead. If you haven't set up, have your things at your bedside, you're still going to have to go ahead and get the dressing and all of those things, to occlude, not necessarily occlude completely, but to put on, on the site, at the site. So the tubing is disconnected. The first thing you want to do is put it in the water to help with that seal, all right? So place the chest tube in sterile water to create a temporary seal and prevent air entry is the first thing you're going to do. Clamping the tube, you're putting the patient at risk for what? If you clamp the tube for this patient, what are you putting the patient at risk for? All right, it was nice meeting you, Diego. All right. How do I put this user in timeout? 24 hours. Okay. All right. You're going to put your patient at risk for pneumothorax. Yes, tension pneumothorax. All right. Yes. Infection. Well, they're going to be at risk as well for infection, but the tension pneumothorax you're thinking about, just think of it that you clamp off this tube. All right, you clamp off the tube, you're going to have that buildup of the air in that lungs, and so you're going to have the patient, just inflating, lung will relapse. Okay. All right, so just think of that happening. Calling the provider is something you definitely will be doing. Apply your occlusive dressing eventually is something that you're going to be doing. But the first thing you want to do is get that tube in the sterile water to create that temporary seal for that pneumothorax. All right. Which patient is at highest risk for pulmonary embolism? Is it the young adult with asthma, A, B, the middle-aged smoker with pneumonia, C, the elderly patient with a post-hip surgery, or D, the patient with chronic bronchitis? So which patient is at highest risk for pulmonary embolism? A young adult with asthma, B, middle-aged smoker with pneumonia, C, the elderly patient post-op his surgery, or D, the patient with chronic bronchitis. C, definitely C. Why, Angel? Why you cancel? Why you take back your answer? You're actually correct. All right, C is the correct answer. The patient with the post-op surgery. All right. So any form of orthopedic surgery that has been done, those patients are always going to be at risk for throwing clots. All right. So you want to make sure you're monitoring those patients well, because you can have the PE. All right. You choose too soon. Okay, that's fine. All right, John the Measurer had said D, the patient with chronic bronchitis. That would be like very, 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 very low on the list for PE. All right, post-op elderly patient is most at risk. Exactly. Patient, middle-aged smoker with pneumonia. Smoking will, put you at risk for clots as well, but I think that is gonna be probably moderate. All right, the patient with asthma and the bronchitis is going to be like very, very low in terms of risk. All right, so DVT risk is highest in immobility and orthopedic surgeries. So definitely you want to make sure you're keeping an eye on those patients. All right. A child with suspected epiglottitis is drooling and leaning forward. What is the priority nursing action? So you have a child that is suspected to have epiglottitis and is drooling and is leaning forward. What is your priority nursing action? A, insert a tongue blade to assess. B, prepare the patient for intubation. C, encourage coughing. Or D, start chest physiotherapy. So you have a patient with suspected epiglottitis. The patient is drooling and the patient is also leaning forward. What is your priority nursing action? A, insert a tongue blade to assess. B, prepare the patient for intubation. C, encourage coughing. And D, start chest physio. All right, so Carousel says B. Kerry, welcome. It's been a while. All right, Y Angel says B, prepare the patient for intubation. B, Kerry says, definitely. All right, so you want to make sure you're maintaining airway for these babies or children, you understand, that has epiglottitis. So the mere fact that they're drooling, all right, there's some form of obstruction going on there. So you want to make sure you secure that airway. So get that patient prep ready for intubation. All right. Never go ahead and use a tongue depressor in that patient's mouth at that time. All right. Because that can further worsen their obstruction. All right, so definitely go ahead and get that patient prepped for intubation. Encourage coughing. Starting chest physiotherapy, those are not really, needed right now. All right, for this patient. So definitely you want to maintain airway for this patient. So epiglottitis, is it something that we can have those patients sit down and wait for in the next few hours, or what? Is it something that we definitely need to drop everything and run for? Or, or we can just have them wait for a few more hours? No, definitely. All right, that's a very, very, very big emergency that you want to get sorted out. All right. Which assessment finding best indicates tension pneumothorax? A, subcutaneous emphysema. B, tracheal deviation. C, chest pain on inspiration. D, diminished breath sounds. So you have a patient that has tension pneumothorax. Which assessment finding best indicates that this patient is having a tension pneumothorax? All right. A, subcutaneous emphysema. B, tracheal deviation. C, chest pain on inspiration. D, diminished breath sounds. All right, so Carrie says B. I don't know if that B. Carousel says B, definitely. All right, tracheal deviation. Why? Why is the tracheal deviation something that you guys are concerned about for the tension pneumothorax? Why? Why you're saying that? Why couldn't it be the subcutaneous emphysema? Why the tracheal deviation is something that is gonna be like, saying, hey, this patient is having tension pneumothorax. What's going on there? Yes, Ariane?
I can't see in the dark.
Here we compromise.
Can I have even more light?
Sure.
Okay.
Uh-huh. So the others can be symptoms of other respiratory problems. Yeah, airways priority. Okay. Right. It's a classic sign. I'm looking for something more. Impaired oxygenation. Okay. So because you have the tension building up and the oxygen is not, the air is not able to release. All right, it's not releasing from the lungs. What is happening? You have just think of it like you have two balloons, and then the pressure is like, you puncture one and you're letting out the air in that one. So all of it is gonna go over to the other side. So you tend to have just remember how the trachea is and the lungs are, all right? Just imagine that all of that pressure now is gone onto one side. You're gonna have that pull on the trachea, so you have the deviation there. So all of that pressure that is being built up is causing that, all right? Emergency, hard to breathe. Yes, think you're answering for the, for the epiglottitis, why, Angel? No, I'm not. I'm Jamaican. All right, I'm Jamaican. Okay. All right. So definitely. So you have tracheal deviation, which is like the hallmark of tension pneumothorax. So it deviates away from where the tension is actually building up. All right. A nurse hears expiratory wheezing in a patient with asthma. After giving albuterol, the wheezing stops suddenly and the patient is silent. What is the nurse's next action? So you have a patient that is having expiratory wheezing and the patient is asthmatic. You went ahead and give albuterol, and as soon as you give the albuterol, the wheezing stop. All right, suddenly the patient is silent. What is the nurse's next action? A, document as improvement. B, notify the provider immediately. C, give another nebulizer treatment. Or D, encourage coughing. So you're having this patient who is having expiratory wheezing, you give them some albuterol. As soon as you give them, it stops. The patient stops, the wheezing stop, all right? And the patient is silent. What is it that you're going to be doing next? A, document as improvement. B, notify the provider immediately. C, give another nebulizer treatment or encourage coughing as D. So Carousel says B, which is notify the provider immediately. Sonja Livingston says A, document as improvement. All right. And Kerry says B, notify the provider immediately. What are you thinking? Why this patient you're going to run to the doctor and call him and say, hey, this is what is happening. Why this patient you're going to call the doctor immediately? Why you never wanted to do something else? Status asthmaticus, B, okay. So Carousel, why did you say B? Airway obstruction. Okay, so definitely this patient is having severe airway obstruction. So you want to make sure you call the doctor, because this patient is going to need to be intubated because of the fact that this airway is compromised, all right, or further compromised. So you're having respiratory failure going on or is about to take place now. All right, so you definitely want to call the provider, and then from there, document as improvement. It's not improvement. Who had said that? Someone had said document as improvement. All right. You definitely want to go ahead and notify the provider because this patient is having a silent chest. All right. Thank you, Y Angel. Thank you. Which oxygen device delivers the most precise oxygen? So if you have a patient that has, for example, COPD, and you want to give them a specific amount of oxygen, which oxygen device would deliver that set amount? I want you to go ahead and just type it in the comment section without me giving you the options. What is it that you're going to run for in terms of that device? Nasal cannula. So which device gives you, like, you know, the set amount of oxygen? So for example, you have your COPD who you definitely don't want to give, 10 liters, 15 liters of oxygen. You want to give them just like 2, 3 liters. All right. What device can you just go and grab and just set it at that and give them the amount that you want? So is it A, the non-rebreather mask, B, the Venturi mask, D, the nasal cannula, or C, the, which direction may I say, simple face mask? So non-rebreather mask, simple face mask, the Venturi mask, or the nasal cannula. So Shelly says non-rebreather, Venturi is for carousel. Okay. So yes, carousel, the Venturi. So remember that the non-rebreather, how much oxygen, what's the range for that? A specific device is definitely the Venturi mask. All right, so let's pull up that one. They come very color-coded. So the Venturi mask. 80 to 100% for the non-rebreather. All right, so the Venturi mask is a mask that is used to deliver a specific controlled percentage of oxygen to patients who require high flow oxygen at precise concentration. All right, so sometimes you'll see them looking like with orange, pink, green, yellow, blue, they have specific amounts. So for example, I really don't know which one is for, let's say you want a patient on the COPD patient on very low oxygen. You want a patient on the 3% or a certain percentage. Then you probably grab the blue one. So when the respiratory therapists come in, they can always just look and say, oh, it's a pink one. Probably the patient is on this amount. You understand? Because they're color-coded and have a set amount that you will give. So the non-rebreather is your 80 to 100% in terms of the concentration of oxygen. Your nasal cannula can go up to how much? Is it 6? Is 6 liters on your nasal cannula? Let's look at them. So your 6 liters, yes. All right. Senior. Hi, Shane. Hi, Senior Ellis. All right, so let's look at the different ones. Your simple face mask, how much can you give on your simple face mask? I'm good. All right, so your nasal cannula is 2 to 6 liters via nasal cannula with a FiO2 of 25 to 40%. The simple face mask is 6 to 10 liters, 35 to 50% FiO2. Venturi mask is 3 to 10 liters, 24 to 60%. You have the non-rebreather, which is 10 to 15 liters at 80 to 90% FiO2. And you have your high flow nasal cannula, which is 30 to 60 liters of oxygen. And that one is giving you a 100% FiO2. All right. So the Venturi mask is the one that gives you the specific, precise concentration for your oxygen. All right. And this says it's especially useful in your COPD patients. All right. So let's go ahead and top up the live. Let's try to get to 3,000. All right. Let's just kind of refresh a little bit. Remember, if you haven't subscribed as yet to my YouTube page, go ahead and subscribe at ThinkNursing. One word. Follow me on TikTok here at ThinkNursing as well. Join us for the live at 7 p.m. on Tuesdays and Thursdays where we do NCLEX questions. I still pop in at 7 p.m. during the week for chit chat, and from there. All right, so go ahead and follow me, and then from there we'll continue. All righty. So, yeah, we'll get there. Why Angel was saying not sure. And for all the persons on YouTube, if you haven't followed us yet, go ahead and subscribe and come over to TikTok as well and do the same. All right. Thank you guys for the follow. All right, let's get cracking again. A client with COPD reports. Thank you. A client with COPD reports increased dyspnea and thick green sputum. Which order should the nurse implement first? So you have a COPD patient, and the patient is having shortness of breath. The patient is dyspneic, and the patient is having thick green sputum. Which order should the nurse implement first? A, collect sputum for culture. B, administer prescribed antibiotics. C, administer oxygen at 2 liters via the nasal cannula. And D, encourage fluids. So you have the COPD patient that is having shortness of breath, and the patient is also having thick green sputum. Which order will you go ahead and implement first? A, collecting the sputum for culture. B, administer prescribed antibiotics. C, administer oxygen at 2 liters via nasal cannula. Or D, encourage fluids. Thank you guys for tuning in. All right. So which of them is it that you're going to do first for this patient? And remember, you have to do something. We're not killing off any patient over here. All right. So you can't leave the patient bedside and not do something. So K says C, administer oxygen at 2 liters. Robbie says C, nice. All right. Anyone on YouTube here? C first? Okay. So definitely you want to go ahead and do C. Always go with your airway first. Airway, breathing, circulation, and always think about the safety of the patient. All right. And if you're thinking about the safety of the patient, the airway is always going to be the one that you want to protect first. All right. So CABD. Okay. So C, which is administer the oxygen. A, collect the sputum for culture. B, administer prescribed antibiotics. D, encourage fluids. If this patient is admitted and you're supposed to get a culture for this patient, when would be the best time for you to collect the sputum? Morning, noon, or night? So when would be the best time to collect a sputum on a patient? This patient, early morning, definitely. All right, definitely. But you know, catch it whenever you can get it, you take it. You understand? Sometimes, whenever you can get it, you take it. All right. But if you can get it early in the morning, that's always gonna be the best time to get one of your acid fast testing going. Hi, Renorta. Welcome, welcome, welcome. All right. And if you have orders for antibiotics. All right, if you have orders for antibiotics, what are you looking for in terms of additional orders? Or what will you be thinking? The doctor orders antibiotics and that's it. And a chest x-ray and, some additional fluids, the oxygen. Is there anything else you'd want to do before your antibiotics? Apart from your culture? You're probably thinking morning before the first dose of the antibiotic, definitely. All right. Would you want any blood cultures? Would you be thinking about any blood culture for this patient? Or you just want, the sputum? Yes, so definitely. So if the doctor orders antibiotics, and even if they never put it in the order, the order set, and you see that they order the antibiotics, don't just run and just give the antibiotics. and think that they only want the culture for the sputum. Go ahead and say to the doctor, hey doc, you want us to just implement the whole sepsis protocol? Do you want me to get your blood cultures, your lactic acid, things like that before you load up the patient with the antibiotic? All right, so get all of those out of the way if you can. Get your two lines, your 2 set of blood cultures, and then you go ahead and give your antibiotic. All right. And encourage fluids. Definitely encourage your fluids to help with that secretion there. All right. So always prioritize your oxygenation. Antibiotics and cultures are important, but airway breathing comes first for this patient. All right. And thank you for the gifts. All right, the rose there. Miss G, welcome. All right. Remember to go ahead and tap up and remember to follow me as well. All right. On TikTok as well as on YouTube at ThinkNursing. All right. So you have a patient here that is just coming out of surgery. So a post-operative patient suddenly develops severe dyspnea, tachycardia, and anxiety. Which order should the nurse implement first? So green mucus would usually mean what? Yes, so Shelly's asking, green mucus would usually mean what? What are you thinking? So if you have a patient that is coughing up green, mucus, what are you thinking? Infection, definitely. Yes, you're thinking about some infection going on. So Shelly was asking that. I think probably Shelly know already, but she just wanted you guys to answer it today. Yes, Matthew. All right, bronchitis maybe, pneumonia, things like those. All right, so definitely you want to make sure that you get your samples, get those out of the way, and then you start your antibiotics. All right. So you have a post-op patient that suddenly develops severe dyspnea, tachycardia, and anxiety. Which order should the nurse implement first? A, prepare for intubation. B, apply oxygen. C, start IV fluids. Or D, administer morphine. So you have a post-op patient who suddenly develops dyspnea. The patient is tachycardic and having anxiety. Which order should the nurse implement first? A, prepare the patient for intubation. B, apply oxygen. C, start IV fluids. D, administer morphine. B, okay, nice. B, all right. Yes, so definitely apply oxygen. Would you go ahead and prepare this patient for intubation? Or that kind of just a little bit extreme with all of these things that, the signs and symptoms. Yeah. It's a little bit too much for what is going on. I understand the patients have severe dyspnea, tachycardia, and anxiety. I think we probably could work on a few things and see if that improve, and then, always have your intubation kit ready. Starting IV fluids. Yeah, you still give a post-op patient some IV fluids, but this one will really help with the situation here. Administer morphine. Would morphine be a good choice for this patient for pain management, anxiety relief, and all? Would morphine be a good choice for this patient for pain management? No? Why you say no, Renorta? Huh? I think morphine would work for this patient. The patient is already dyspneic. Okay. I think the patient could actually get this for pain, especially no, morphine depress the trap system. So morphine depresses the trap system. Okay. So the patient could I think the patient could probably benefit from like the low dose of the morphine for this pain, and also help with, this patient that is having the shortness of breath. Probably if the patient is having anxiety, then it also will help with, relaxing that patient a bit. So, but the priority would be to get the oxygen started. You can also give the patient something for the pain management, and then from there. All right. I was going to ask something else. What are you suspecting based on all of these signs and symptoms? What are you suspecting for this patient as a complication? So this patient just came respiratory type 0. Okay. What is a complication based on the scenario here? A post-op patient suddenly developing severe dyspnea, tachycardia, and anxiety. What are you thinking for this patient? So Champagne says bleeding. That's not what I'm looking for. Post-op patient is going to be at risk for bleeding. But this patient that is in front of you, who is having these symptoms, no. What are you concerned about outside of bleeding? So the patient is dyspneic, the patient is tachycardic, the patient is having anxiety. Yes, Sanja, you're thinking about a clot, all right? You're thinking about a clot here, your PE. So always remember, your post-op patients are always high on the list for PE, all right? You're always at risk for your embolus developing. And the mere fact that the patient suddenly develops severe shortness of breath, the patient becoming dyspneic, that is something that you definitely need to, keep an eye out and address immediately. All right, so what are you expecting? So this patient just came out of surgery. The patient is having all of these symptoms. The patient is dyspneic. And, they're thinking about a PE. Would this patient still be a candidate for your high-dose heparin? Or would you be thinking about heparin for this patient or anything like that, blood thinner? Would you be thinking about it? Yeah. But the patient a bleed. The patient just come out of surgery, Robbie. Why you want to give the patient so much, heparin infusion? Yes. Yes. So definitely the patient is going to be probably placed on some infusion to help with thinning out that blood or, breaking up that clot. All right. So definitely you want to make sure that that patient, if they're thinking along that line, they're going to be starting, the heparin infusion or whatever it is they order. For that patient. All right, Flotrons. All right, Kerry says low dose. Okay. All right, so oxygen is always the first step in suspected PE to correct the hypoxemia. All right. A patient with blunt chest trauma has absent breath sounds on the right and severe respiratory distress. So this patient met in an accident, has a chest. Okay, no problem, Shelly. No problem. Not a problem. Thank you so much for that, Heart Me. All right, and for sharing up the live. So you have a patient that has blunt chest trauma, and the patient is having absent breath sounds on the right. What are we thinking? So you have a patient that has a chest trauma and having absent breath sounds on the right. What are you thinking? So you're listening and you don't hear any breath sounds. Pneumothorax, definitely. All right. Hemothorax, no. Pneumothorax, Champagne. All right. So remember, the pneumo is the one with the air. The hemo is the one with the blood. All right. So you're thinking about your pneumothorax for this patient. They can have a pneumothorax as well, But, always start off with, when they give the absent breath sounds, just go with the one with the air first. All right. If the question has anything to do with blood, then you can always go with the hemothorax. All right. So you have a patient that has absent breath sounds on the right, and the patient is having severe respiratory and this patient is severely distressed. So the patient has respiratory distress. What is the nurse's priority? A, notify the rapid response team. B, apply a non-rebreather mask. C, prepare for chest tube insertion. D, place the patient in left lateral position. All right, so you have a patient with blunt chest trauma, and the patient has absent breath sounds and is severely distressed. What is the nurse's priority here? A, notify the rapid response team. B, apply a non-rebreather mask. C, prepare for chest tube insertion. D, place the patient in the left lateral position. So CCCA. So prepare for chest tube insertion. Some persons are saying. And then we have Melissa who's saying she's staying on top of the A game with notifying the provider. All right, notifying the rapid response team, which is correct. All right. And just think about it. You know, if you have this patient in front of you, what are you going to be doing? So the options here says notify the rapid response team. A, apply a non-rebreather. C, prepare for chest tube insertion. D, place the patient in left lateral position. All right. You have to take some time to go ahead and get that patient over to the OR. All right. You have to go, you're going to not over to the OR. You're going to have to get the things ready, get the doctor ready, everybody ready to get that chest tube in. All right. Notifying the rapid response team is going to alert everybody to come to the bedside of that patient. So definitely go ahead. You're thinking about attention pneumothorax. So you want to get your respiratory therapist. You want to get your provider additional help at that bedside. All right. Prepare the patient for chest tube insertion. Yes, we're definitely going to be doing that. But notifying the rapid response team is the priority here based on the answers that they have. All right. This is the attention pneumothorax, a medical emergency. Rapid response is priority. All right, that's true. Rapid. So always think about or look at the answers that you have in front of you, and then from there, just make sure you're choosing the one that is what you can do now. Can I just say call the doctor, or can I put little oxygen on rapid response, whatever it is. All right. ITS Music, welcome, welcome, welcome. Shireen, welcome. How are you guys doing? All right. So always just look at that, and then from there, choose the one that is the most appropriate. All right, we know that this patient is gonna go for, they're gonna prepare the patient for chest tube, but in the preparation phase, you still have to go ahead and alert your providers. Activate your rapid response so everybody can come to the bedside for this patient. I'm doing good. Doing good. Thanks. All right. That's true. Rapid response. Yes. All right. Which patient statement indicates correct understanding of inhaled corticosteroids? Which patient statement indicates correct understanding of inhaled corticosteroids? A, I'll use it for sudden shortness of breath. B, I should rinse my mouth after using it. C, it replaces my albuterol inhaler. Or D, I only use it when symptoms get worse. So you have a patient that is getting, who is an asthmatic, or the patient is COPD, and the patient is getting inhaled corticosteroids. All right. Which one is the best answer for you to say that the patient understands the role of this medication? A, I'll use it for sudden shortness of breath. B, I should rinse my mouth after using it. C, it replaces my albuterol inhaler. Or D, I only use it when symptoms get worse. Kerry says B. All right, no problem, Shelly. Thank you so much for stopping by. Robbie says B. Nice. So I should rinse my mouth after using it. Why are we encouraging the patients to have good mouth care or rinsing their mouth when they're using these corticosteroids? Thank you for the gift and for liking up the live. TS, to prevent thrust. Okay, all right. So definitely you want to encourage these patients to go ahead and do, when they're on these medications long term, you want to encourage them that, they always need to go in and get their dental, follow-up or evaluation done. You want to make sure that they're brushing their mouth, their gum properly, things like that, because you don't want anything to be building up there. So you're preventing the oral thrush in those patients. So corticosteroids are for prevention and maintenance, not rescue. What would be a rescue inhaler for this patient? So if we're using a corticosteroid for maintenance, what is the example of emergency? One of those emergency inhaler for the patient, or the rescue inhaler, the albuterol. All right, and albuterol is what kind of drug? What class of drug is the albuterol? So we know it's an inhaler. What class of drug is the albuterol? A beta 2. Okay. It's a bronchodilator. All right. So it is a short-acting bronchodilator. It's a beta 2 drug. All right. So that is the one that, you know, when they're having their shortness of breath, you want to go ahead and tell them, go ahead, grab your rescue inhaler and take that one to open up the airway, help with, you know, oxygen going into the lungs. And then the corticosteroid, that one is going to do what? So you have one that is opening up the airway, and then what the corticosteroid is going to do? What is the corticosteroid going to do in your asthma patient? Help with the inflammation. Okay, definitely. It's going to help with the inflammation. So dry up some of the secretion. Yes. Decrease the inflammation and all of those things. Reduce swelling. Yes. All right. So corticosteroids are for prevention and maintenance, not rescue. Rinsing mouth prevents oral thrush. All right. So you have a patient on a mechanical ventilator who suddenly has decreased oxygen saturation and hypotension. What is the nurse's priority action? So you have a patient that is on a mechanical ventilator and the patient suddenly develops decreased oxygen saturation and hypotension. What is the nurse's priority action? Is it A, increase the FiO2 on the patient, B, check for kinking or disconnection, C, notify the provider, or D, suction the airway? So you have this patient who is on a mechanical ventilator and the patient suddenly develops decreased oxygen saturation as well as the patient becomes hypotensive. What is going to be your nursing priority here? A, increase the FiO2 on this patient. B, check for kinking or disconnection. C, notify the provider, or D, suction the airway. Champagne says D, suction the airway. Robbie says B, check for kinking. Melissa says B, check for kinking. All right, so definitely you want to go ahead and check for kinking for this patient or make sure it's disconnected. All right, so always go ahead and assess the, you know, the device, assess the patient, things like that. So if you have this patient who suddenly develops decreased oxygen level or the patient becomes hypotensive, go ahead and check your system to make sure that everything is fine. All right, check the system to make sure everything is fine. If something is disconnected, if something is kink, that is contributing to that sudden drop or change in the patient's vital signs. All right, it's the same thing like when you have a patient that is on the electrodes. And you probably walk into the patient's room and you know that this patient was alive and well, talking on the phone for hours, but now you see asystole on the monitor. All right, don't grab those paddles and try to go and do anything. All right, just go ahead and check to make sure that the leads, the electrodes are on the patient, you know, because that happens a lot of time. The electrodes fall off and then the patient is in asystole on the monitor, but the patient is alive and well, just sleeping. All right, so always check your system to make sure everything is fine. Then go ahead and, you know, determine what is happening. All right, so for this patient, if it suddenly happen, don't just think that, you know, the patient will suddenly start deteriorating. You understand? Usually you'll see signs of things happening before, you know, you reach to a hypotensive state or the oxygen saturation just drop from 100 to 70%, you know, as soon as you wink. So go ahead, check your system and then from there. All right, increasing the FiO2 on this patient. You know, I know a lot of times we'll probably run and say we're going to turn on. Nothing is wrong with increasing your oxygen, but first, make sure that the numbers you're getting is representing the patient that is in front of you. All right, so check your system first. Notifying the provider, eventually suctioning the airway. Depends on what you're suctioning for. You know, if the patient, if you go and you see that the patient has secretion, nothing is wrong with suctioning the patient. But if the patient is intubated and you know that 5 minutes ago everything was fine, you look at the patient, there is no secretion, then always just go ahead. Don't waste the time and try, you know, suction something that you're not seeing, like you know, just go ahead and check the system to make sure everything is fine, and then from there. All right. A patient on 100% oxygen, got to run, enjoy the rest of your life. Not a problem. Thank you so much for tuning in. All right. A patient on oxygen, a patient on 100% concentration oxygen for... not a problem, Miss G. Not a problem. Thank you so much, though. Oh, thank you for the gift. Thank you for the gift. All right. All right. So a patient on 100% oxygen for 24 hours is now restless and coughing with substernal pain. What is a likely complication for this patient? So you have a patient that is on 100% concentration of oxygen. All right. The patient is now restless and coughing with substernal pain. What is the likely complication for this patient? A, atelectasis. B, oxygen toxicity. C, pulmonary embolism. D, aspiration pneumonia. So the patient is on 100% oxygen for 24 hours. The patient is now restless and coughing with substernal pain. What is the likely complication for this patient? Sandra says B. Robbie Champagne says B, oxygen toxicity. All right, what are you thinking about? So based on what is happening with this patient, what are you thinking about in terms of why the patient is having the substernal pain? B, Melissa is saying B as well. So you know that the patient is having the oxygen toxicity, that, you know, there's just too much oxygen on board. Hyperoxygenated, definitely, yes. So what is going on? If you hyperoxygenate something, or just think of the grapes, some balloons, and you're putting too much oxygen in there, what is happening to those alveolars in the patient's lung expansion? Okay, you understand? Eventually the patient will feel it, you know. The patient will feel it, you understand? So you're gonna have that alveolar damage taking place. The patient is getting, you know, restless, all of those things going on. All right, the patient might just be tender in the lungs there, or in the chest there. All right. For this patient that is on the 100% oxygen, what device are we thinking the patient is on? Is the patient on a non-rebreather? The patient is on, like, you know, a venturi mask. The patient is on a simple mask, nasal cannula. What oxygen device are we thinking this patient is on? BiPAP, what? So if the patient is on 100% oxygen, what are we thinking about? Non-rebreather. Anybody else? A non-rebreather, definitely. All right. So, yes. All right. So always think about these patients. Prolonged high oxygen causes oxygen toxicity, alveolar damage, restlessness, and cough. All right. If the patient was having aspiration pneumonia, if you are thinking that the patient is having aspiration pneumonia, what are some of the signs or symptoms this patient would be having? So if this patient is having aspiration pneumonia, what are some signs and symptoms? Not necessarily on the high flow oxygen here, but in general, what are some of the signs and symptoms you're looking for a patient who is on aspiration pneumonia, or who is having aspiration pneumonia? They'll be having the coughing. Okay. What else? Stridor, tachycardia. Okay. Low O2 sat, yes. And then you always just, you know, think about different things. Like, so for example, if depending on what does the scenario gives you, you understand? Because for example, you have a patient that is always lying in bed, eating, things like that, your elderly patients, then definitely you'll find out that those patients are at higher risk for your aspiration pneumonia. You understand? Pulmonary embolism, we talked about that earlier, the same tachycardia. So it depends on what is going on with the patient. A lot of these respiratory symptoms are basically the same. The presentation can be similar, but based on the scenario that they give you, you choose the best answer for that. All right. And that's it for the pulmonary embolism, where you talk about the chest discomfort and everything. All right. Which, say you have a patient that is suspected to have SARS, all right? Which infection control measure is most important for that patient? Is it A, standard precautions only, B, airborne and contact precautions, C, droplet precautions only, or D, protective isolation? So, a patient that is suspecting to have SARS, all right? Which infection control measure is most important for this patient? B, so B is airborne and contact precautions. A, standard precautions only. C, droplet precautions only. Or D, protective isolation. So score, I hope I say it properly. Score says B. Kerry says B. All right. Nice. So the airborne contact precautions is the one that you'll definitely want to be using for this one. Why both of them? Why not just like, you know, your airborne? Why you want to go ahead and do the contact with this one? Or both of them just work hand in hand? What are you thinking? So what's special about the airborne precaution or the droplet? The airborne precaution. For this patient who is on, you know, this kind of precaution, what is one thing you definitely want to have? You want all APPEs, you know, you want all of them. But what is it that is going to be different in terms of the setup with this patient? Your N95, definitely, sure, and carry. You want to make sure you have your N95 for these patients. Get them in a negative pressure room. All right, cross-contamination to other patient, definitely. So you'll want to have your contact precautions as well being implemented. Standard precautions only, no. Standard precautions is right across the board, you know, for everybody. Even though sometimes they will tell that, oh, you know, yeah, it goes across the board for everybody, for all of the people, the infection control measures you're thinking about. Droplet precautions only, no. You want to do the airborne precautions with the N95 and everything else. And protective isolation, as I say, you put this patient in your negative pressure room and keep them away from everybody. All right, keep them away from everybody. So SARS require both airborne N95 and your contact precautions due to the high risk of it being so contagious. All right, so you want to keep those patients away. Thank you for sharing up the live. Let's see if we can tap up to 5,000. It's not that bad, not true. Yeah, 5,000 not that bad. Let's go ahead and tap up to the live on to 5,000. So we can get other persons who are interested in the content over to the page. That's all it's going to do. All right, you're not going to tell anybody, say, you know, you tap up the screen. Even though we see it. We know that you tap it. So just go ahead and tap up the live so we can get some more persons over on the live who wants to be a part of the page. All right, what you guys can do on YouTube now is also go ahead and follow me. Go ahead and follow me on TikTok at ThinkNursing. And, you know, you guys on YouTube or TikTok can go ahead and follow me on YouTube at ThinkNursing as well. Remember, subscribe to my page. All right. So just in case you missed the entire live, you can get it over on YouTube where it's also streamed. All right. So definitely do that. Thank you so much for the follow, guys. All right. So it's 8 o'clock, so that's 1 hour. So we have 1 more hour to go. I'm only doing 2 hours today, no 4-hour class. I have work tomorrow, I think. All right, so which task can the nurse delegate to the UAP, which is the unlicensed assisted personnel, for a patient receiving oxygen therapy? All right, so which task can the nurse delegate to the UAP for a patient receiving oxygen therapy? Val, welcome. Is it A, adjust the oxygen flow, B, educate about safety precautions, C, check the skin around the ears and the nose for breakdown, or D, teach pursed lip breathing? So which task can the nurse delegate to the UAP for a patient receiving oxygen therapy? Is it A, adjust the oxygen flow, B, educate about safety precautions, C, check the skin around the ears and the nose for breakdown, sorry, or D, teach pursed lip breathing? C. Sorry. All right. So adjusting the oxygen. So C. Okay, nice. So check skin around the ears and nose for breakdown. Wouldn't that be like considered to be like assessment as well? What you thinking? Or are we looking at the fact that, you know, they just use the word check? Is that what we're looking at? Okay, so adjusting the oxygen flow. Okay. The other options are not for the UAP. Okay. Educate about the safety precautions is for the nurse. Adjusting the oxygen. The oxygen is medication, so you can't give anybody else that. It might sound simple, you know, turn that thing down. It is very simple, but it's not for your UAP or for anybody. It's for your RN. All right. Educating the patient. That is going to be for your RN. You can, who is it again? The LPNs can re-educate. So you have to do the initial education. The C, which is the teaching per slip breathing. Teaching is a part of your RN responsibility as well. And C, even though it says check skin around the ears and the nose for skin breakdown, even though it sounds like assessment, out of all of these that you have here, that one would be something that you could say, okay, then you can just go ahead and give to your UAP to do. All right. So yes, not assess. All right. So anything that has to do with teaching, educating, assessment, medicating, those are always going to be for your RN. All right. Somebody here. So Robbie says it's a form of assessment, but they only going to inspect. Okay. Larissa, welcome. Oh my goodness. I remember you had sent me a message. I'm going to have to go back through your thing if you're still on the page here. Welcome. All right. So folks, if you haven't subscribed as yet or follow, go ahead and follow Larissa. Larissa here. She does her live on TikTok here as well. How do I do this? So definitely go ahead and, you know, follow her page. All right. She's a nurse as well, entrepreneur, a bunch of different things. Just go over to her page and just, you know, sit down and listen. You'll learn a lot over there. All right. All right. So yes, it's a form of assessment, but they're only going to inspect. All right. No problem. But as I say, you know, out of everything else that is on the list there as a task, that's the one that, even though inspecting, assessment, basically the same thing, you know, that's the one that would be like okay for your UAP. All right. Blessed Kia, welcome. So UAPs can observe and report, but not adjust, interpret, or teach. All right. You have a patient with acute pulmonary edema, and this patient is in severe respiratory distress. The patient is also having frothy pink sputum, and the oxygen saturation is 78%. What is the nurse's priority here? A, administer furosemide, IV. B, position the patient in I-Folus position. C, start oxygen with non-rebreather mask. Or D, call rapid response. So a patient that has pulmonary edema, the patient is severely distressed. The patient is also having frothy pink sputum. The oxygen saturation is at 78%. What is the nurse's priority? A, administer furosemide IV. B, position in I-Folus position. C, start oxygen with non-rebreather. Or D, call rapid response. What are you going to be doing? So you're at this patient's bedside and you see all of this thing going on. You know that this patient has pulmonary edema. What is it that you're going to be doing for this patient? You look on the monitor, it's good waveform, oxygen saturation is 78. You're there, the patient is having some frothy pink sputum, the patient is just severely distressed. What can you do? You are gonna do D, which is call rapid response. B, Robbie is saying B. Carousel is saying B. Okay, B. All right. So Kerry is saying B. So yes, so B. How many persons said B? Position in high folders, position. Okay, position in high folders. Okay. So what about so let's go again. So the patient has acute pulmonary edema, is in severe respiratory distress, frothy pink sputum, and oxygen saturation. What is the nurse's priority here? All right, what is the priority for the patient? A, administer furosemide IV. B, position in high folders position, folders. C, start oxygen with non-rebreather. Or D, call rapid response. What is going to be your priority here? I see everybody said high folders position, and one person said call rapid response. A, B, C rules. Champagne says C. Kerry says C. What was the question? A patient with acute pulmonary edema is in severe respiratory distress. The patient is having frothy pink sputum, and the oxygen saturation is 78%. What is the nurse's priority? A, administer furosemide IV. B, position in high folders. C, start oxygen with non-rebreather. D, call rapid response. So what is the nurse's priority here? C, all right. If you're supposed to ask, what will you do first? Then that's something Kerry says first versus priority. Yes. Now, what is the priority here for this patient? All right. So always think about your ABC rule. Airway, breathing, circulation. The SAT is 78%. All right. If you're thinking about what is it you're going to do first, you probably end up either pressing the, if the option has to call rapid response, put the head off the bed or put the patient in folders position, then you probably start with stuff like those. But what is your priority here is for your airway. All right. Airway is always going to be priority. Then what would you do next? Then, you could actually look at it like that. So the priority thing here for this patient is starting the oxygen with the non-rebreather. All right, get the patient stabilized. The saturation is like 78%. All right, saturation is 78%. Are you thinking about the priority C? Yes. But then if the question was asking like, what would you do first? You probably end up and just pull it off the bed up. You understand? Put the patient in a folders position. Because that's what, you'll be thinking about. Patient probably a little bit too low, so you want to get that lungs expanded. So you probably put the patient in high folders position. The things like those. So remember to look at the keyword that they're using in the sentence. All right. So starting your oxygen is priority for this patient. All right. You're thinking about the safety of the patient. All right. When you think about, what is it that you're going to do first? Then you'd say, okay, then get the patient in a high folders position, press the rapid response, things like those. All right. And then from there. So oxygen first to stabilize airway breathing, diuretics and positioning follow, but oxygen is priority. All right. Are you anticipating that this patient might get intubated or not? So you have this patient with acute pulmonary edema. The patient is severely distressed. So are you thinking along that line that this patient could end up getting intubated? Yes, we're thinking along that line. All right, we're thinking along that line that this patient might end up getting intubated, especially with the fact that the saturation is so low. Patient is severely distressed and the patient has a lot of fluid there in the lungs. All right. So hopefully they'll give that furosemide. We'll probably do 1 or 2 little things for the patient, but I think I'm anticipating that this patient will be intubated. All right. Which assessment finding is concerning in a patient with flail chest? So what is flail chest? If somebody asks you what is flail chest, what would you say to that person? If somebody say, you know that a patient has flail chest, what is it that you're thinking? What's the description you'd give them? Thank you for the follow. Score or sure. If somebody says that that patient has flail chest, what are you thinking? Is it with flail chest you have like the multiple rib fracture on, like you have multiple rib fractures on one side, and so you have the asymmetrical sunken in, yes. All right, but it has to be a specific amount. Let's look at that. Flail chest. All right. So it is a serious chest wall injury where multiple broken ribs create a separate, detached section of the rib cage that moves in the opposite direction of normal breathing. All right, this paradoxical motion hinders breathing, causing severe pain, difficulty inhaling, and potentially leading to underlying lung collapse or lung damage. All right, so when you have the patient with flail chest or any form of like, rib fracture, you're always thinking about your pneumothorax. All right, you're always thinking about your pneumothorax because just think of that patient, breathing in, exhaling. There's a high possibility that lungs can actually get punctured by that broken rib. But just think of it that you have 3 ribs on the same side, fracture. You're gonna be at higher risk for your pneumothorax there. All right, so it's caused by high impact blunt trauma like car accidents, fall, and requires immediate medical attention, including pain management, respiratory support, and potentially surgery. So these patients, yeah, man, don't let them beg for them pain medication. Just give them. You understand? Just give them pain medication. Because not only you're addressing their pain, but you want them to be so relaxed, so comfortable that, you don't want them to be in so much of a pain, breathing so fast, and then putting them at higher risk. We already know that they are at risk for their pneumothorax. You don't want to put them at higher risk for lung damage. All right. So a lot of times these patients tend to end up like on the ventilator, depending on the amount of, ribs that they get fractured. All right. So for that patient, make sure you're getting them their pain medication. So which assessment finding is most concerning in a patient with flail chest? A, paradoxical chest movement. B, severe pain on inspiration. C, subcutaneous emphysema. D, increasing restlessness and hypoxemia. So which assessment finding is most concerning in a patient with flail chest? A, paradoxical chest movement. B, severe pain on inspiration. C, subcutaneous emphysema. Or D, increasing restlessness and hypoxemia. Kerry says A, paradoxical chest movement. Melissa and Carousel says D. Kerry changes her mind and says D, which is the increased restlessness and hypoxemia. Yes, because paradoxical chest movement is one of the classic, sign of a patient with flail chest, because you have that area where, you have the multiple fractures there. So you're going to have that chest movement there. Severe pain on inspiration is something that is going to be expected. Subcutaneous emphysema. And so the one that is going to be most concerning is your increased restlessness and your hypoxemia there. You're thinking about what? What are you concerned about? So if this patient is having increased restlessness and the patient is becoming hypoxemic, even worse, you understand? You realize that the oxygen was at 90. Now the patient becomes so restless. The oxygen saturation is at 80. 15 minutes later, it's at 60. What are you thinking? So that's when you're going to the doctors are going to be making that decision to go ahead and intubate that patient. All right, because this patient is having some form of impending respiratory failure. They're worsening. So you want to go ahead and protect that airway for that patient. All right, so restlessness and hypoxemia is leading to worsening oxygenation, which is indicating impending respiratory failure for that patient. All right, and then make sure that they're getting their pain medication and everything. All right. Which teaching? Any questions so far? I know we've been like, yapping. Any questions so far? Or additional question? No? All right, let's top up the live to 6,000. That's all we're gonna do. Top up the live for 6,000 to 6,000. Thank you so much. Thank you, Carrie, for saying that. All right, let's just top up the live to 6,000. Get some more other persons over here. This is a wee. Carousel, you sleep off. You wake up good though, because you're answering the questions perfectly fine. But thank you for coming back on. A boring, yes, my class boring. No, sir. I have to step up my game. I'm gonna have to step up my game. You understand? I'm gonna have to step up my game. All right, but we will definitely continue with the questions here. And if you sleep off, you just wake up back and wipe out the eyes them and start answer question again like carousel. All right, Destiny Child, welcome, welcome, welcome. All right, thank you, Champagne, for liking up the live as usual. All right, and if you're new here, remember, go ahead and follow me on TikTok as well as on YouTube. If you're missing out on the entire live, they're all posted on YouTube, so definitely feel free to go ahead and subscribe. It's free. It's very, very free to subscribe over there. Subscribe and sit down, grab your popcorn, and do all of them wonderful things there that you normally do on a regular channel, on my channel as well. All right, and at least you'll get to know me a little bit more. All right, you'll get to know me a little bit more and just be a part of the family. All right, thank you guys. All right, so which teaching should be included for a patient starting rifampin therapy? What condition are we thinking about when you hear a patient on rifampin therapy? So a patient is on rifampin therapy. What are you thinking about in terms of the diagnosis? TB, okay. What other medications are you anticipating that this patient would be on with, if the patient has tuberculosis? What other medications can you think of? So a lot of times you'll see those three questions. You will see those three questions on, well, not three questions, those three answers most of the time in the questions on the NCLEX. Yes, ethambutol, you have the isoniazid and the rifampin. All right, yes. So familiarize yourself with those and the side effects that you definitely want to talk to your patients regarding for those medications. All right. So which teaching should be included for patients starting rifampin therapy? A, your urine may turn orange red. B, stop medication when your symptoms improve. C, you do not need to use birth control. Or D, take medication on a full empty stomach. No, a full stomach, not a full empty. So A, your urine may turn orange, red. B, stop medication when your symptoms improve. C, you don't need to use birth control. Or D, take medication on a full stomach. A, your urine may turn orange, red. Okay, yes, definitely. Is the orange red, is that something that, you should tell the patient that, it's very harmful, or what are we going to tell them? Is it something that will just, happen for 1 day, 2 days, and then go away, and they go back to normal looking urine color, or what? Is it something that is harmful? Is it that my kidneys are bleeding out, or what? What is going on? Is it something that is just normal with the medication, or is it something harmful for the patient? Like if the patient says, but nurse, that the urine is just so orange, and regardless, is it? Yes, it is normal. It's not harmful for the patient. It's just a side effect of the the medication. All right, so sometimes patient will come and tell you that their urine looks blue. It's normal for the medication to be causing that. It's orange, it's normal. Once they stop, then their urine usually go back to the original color. All right, so the urine may turn orange red. that is normal with the medication. All right. Do you tell the patients to stop taking the medications when their symptoms improve? Do we tell them to stop taking their medication, or is this something that they're going to be taking for a long time? No, not at all. Yeah, so no. All right. So definitely they take it until, they're tuberculosis free. All right. So they're going to be on it for a long time. All right. You don't need to use a birth control while you're on this medication. They definitely need to use a birth control. All right. While they're on this. Take medication on a full stomach is something that you always, most of the time, you encourage them to take it on a full stomach just because of the GI effects. You want to cut down on the nausea, the vomiting. So you always encourage them to take it on a full stomach. Except what medication? It's not related to the respiratory system. But what is one common medication that we always tell patients? Take it first thing in the morning on an empty stomach, or 2 medications you can think of. Take it early in the morning on an empty stomach. No food, nothing. Which medication you can think of that we commonly will be telling patients to take on an empty stomach? Your omeprazole, and what else? One other medication I'm thinking for endocrine. Your levothyroxine, PPIs, yes. All right, so you always want to encourage your patient to take those on an empty stomach. Every other medication can actually, as far as we're concerned, can take on a full stomach, right? So Rifampin causes harmless red-orange discoloration of your body fluids. The medication must be continued long-term. All right. So if you have a patient that is having pleural effusion, what is happening in pleural effusion? Where are you having the fluid? Where you have fluid buildup in pleural effusion? So you have a patient that has pleural effusion in the pleural space. All right. So you have the fluid buildup is in the pleural space. So what are some of the symptoms or the signs outside of the lungs? All right. So in the pleural space, you'll definitely have the fluid buildup. So what are some of the clinical manifestation that is expected for this patient? A, crackles in the upper lobes. B, dullness on percussion. C, expiratory wheezing. D, hyperresonance. So you have a patient that has, pleural effusion. What are some of the clinical manifestations for this patient? A, crackles in the upper lobes. B, dullness on percussion. C, expiratory wheezing. D, hyperresonance. Carousel says A. Okay. We have anybody else? B, not sure. Okay, so the answer is B. You will have the dullness on percussion. All right, Carousel, why you say the dullness on percussion? So if you remember the different sounds, then sometimes you'll be able to tell based on, the pathophysiology of the condition. All right. So if you have something that is dull, if you hear a dull sound, so for example, you have the pleural effusion, you're thinking about that excess fluid there in that space. When you percuss, you're gonna have that dullness. So I don't even really know how to explain the dullness, but dullness dull. All right, you can hardly hear it, things like that. It's very low. All right, and that's because you have that fluid buildup there. So for example, like your pneumonia, when you have that consolidation, you tend to have like, your dullness when you percuss. All right, because you have that consolidation there. For your hyperresonance, what are you thinking about? Just thinking of hearing the word, or just thinking about hyper, it's going to be like high. All right. Resonance sound. So what are some conditions that you can think about when it comes onto the respiratory system, or even with the organ you're expecting to hear with your hyperresonance? Your COPD, okay. What else are we thinking about for your hyperresonance? So your COPD, your pneumothorax, anywhere that you have too much air building up, you can think of, just think of it that hyper means, just too much, high amount. Yeah, high sounds, high pitch, things like that. All right, expiratory wheezing, you'll hear that in your asthma patient, or, you'll have it in other conditions going on. Crackles in the upper lobes. What conditions are crackles most likely or most often heard in? A lot of times you hear they say, oh, the lungs just sound wet. What are we talking about? You can have it in your pulmonary edema. You can have it in your CHFs, things like that. Anywhere that has too much fluid. All right, pneumonia, heart failure. Okay. So anywhere that has excess fluid, you'll tend to hear your crackles there. All right. So the answer is, for the pleural effusion, the clinical manifestation is going to be dullness on percussion, because you have fluid in the pleural space, you have dull percussion, and you're going to have decreased breath sounds. So when you're listening, it's going to be a little bit diminished, or it might just be decreased. All right, you're going to have to listen real hard. It's not going to be like, your patients who have the pneumothorax. When you put on, before you even probably put down your stethoscope down there, you can hear the sounds like very loudly, going on. Your wig is lopsided. Thank you so much, Haywire. Anything else? Tell me something cute. Welcome to the channel. And remember to go ahead and subscribe. All right? People always go on the live to mix up people, Haywood says my wig is lopsided. AY, I don't know that it's not AY. Haywood don't realize that, my wig is supposed to be like a bob. Yeah, man, that's what I was trying to look. The look I was trying to go for. Of course, Ash Amor. I tell you. Hi, Ryan. Thank you so much for tuning in. All right. So that's what we'll do for that patient. All right. You have a patient that has burn. So you have a burn patient with facial burns. Is that like, something that you're concerned about? Cute. Thank you, Melissa. So you have a patient that is a burn patient with facial burns, hoarseness, and singed nasal hairs arriving in the emergency room. What is the priority action for this patient? All right. So you have a patient that was in a fire. The patient has burn on the face. The patient is sounding hoarse. The patient has singed nasal airway. All right. And that patient presents to you in the emergency room. What is going to be the priority action for this patient without even me reading out the answers, the options? What is going to be your priority for this patient? What are you thinking? Thank you so much, Awood. Thank you for doing that. Airway. All right. Airway is always going to be priority. But what about the airway that we're thinking about? Oxygen for smoke inhalation. Definitely. All right. Airway oxygen. Yeah. So what we're going to do, we're going to put on a 2 liters oxygen via nasal cannula. Is everybody saying oxygen? What are we going to be doing? Let's hear it. What are you going to be doing for this patient? So the patient, burn patient with facial burns. All right. Facial burn. The patient is hoarse. The patient has singed nasal airway, singed ears. All right. HAIR. Sometimes I leave off my H. You understand? So bear with me. So what are you going to be doing for this? Preparing the patient for intubation. You understand? Anytime you hear about any patient involving any form of fire, all right, and the patient is hoarse, you have some form of vasoconstriction going on there, or constriction going on there. And not only that, the patient has facial burns as well. All right. So that patient is going to be at risk for, the swelling So you have the swelling going on there. So you have the occlusion. So that patient is going to sound hoarse, until the airway just lock off completely. So definitely go ahead and try to get that patient ready for intubation. All right. So that's going to be your priority and action. So the options they have are start an IV for fluids, B, apply high flow oxygen, C, prepare for intubation, D, administer pain medication. All right, so you have a burn patient with facial burns, hoarseness, and singed nasal hairs arrived in the emergency room. What is the priority action here? Prepare for intubation, administer pain medication, apply high flow oxygen, or start IV. It's always going to be, you're going to go ahead and prepare this patient for intubation, all right, because that airway is compromised, all right? So you want to make sure that we get something going to have this patient being oxygenated well. So if this patient comes in and the patient hasn't started, you just hear that the patient was involved the patient was in a house and the patient has been exposed to, the smoke. You understand? The patient is talking and everything. What is something that you can actually do? So this patient has been locked in this room for a long time. The patient is not sounding hoarse or anything, but the oxygen level is a little bit low. What can you do or let's say the oxygen level is 90%. What can you do for this patient in the meantime? Well, it's one thing, you need to do for your patients that are exposed to smoke inhalation. All right, they've inhaled too much smoke. What is it that you're going to do for that patient? So, or how do you start out with treating your smoke inhalation patients? What are you going to do? You always see EMS always just put on the patient on these continue to cough in. Okay. So how can you start off with the treatment? So they bring all these patients come and they say all these patients were involved in this house that was burning down. You're always gonna go ahead and give oxygen. All right. So why are you giving oxygen? The patient oxygen saturation at 95%. Why are you going to give the patient oxygen? Why are you going to waste the oxygen carousel? Why are you going to waste the patient oxygen? Why are you going to waste government oxygen or hospital oxygen? What we know about oxygen, smoke inhalation, and what else? You hear about the carboxyhemoglobin. What happens there during smoke inhalation? Carboxyhemoglobin. So you always go ahead and give your high dose oxygen because, yes, carbon dioxide poison. Yes, all right. So let's talk about that. So you always want to go ahead and start your patient on the oxygen in blood is replaced by the carbon monoxide. All right, yes. So always go ahead and start them on some high dose of, oxygen. Put on in rebreathe and max it out. Put it up to 15. You understand? That is the one time you're not going to be concerned about oxygen toxicity. All right, because the patient has inhaled too much, of that smoke. So you want to go ahead and get that out of the patient's body. And the best way to do it is with your high dose or high concentration of your oxygen. So get your patient on your non-rebreather bag, your mask, your oxygen, and just put it up to your 15%, your 15 liters, and get that patient going. All right, so let's talk about your carboxyhemoglobin. All right, so when it comes down to smoke inhalation. So your carboxyhemoglobin is stable complex. It's a stable complex formed when CO2 binds the hemoglobin in red blood cells, replacing the oxygen carrying capacity. All right, normal levels are low, under 3% in non-smokers, under 12% in smokers. All right, so it is a complex form when carbon monoxide from smoke inhalation binds the hemoglobin in the blood, reducing the oxygen delivery to tissues. So even though the patient might seem like, the oxygen levels seem to be okay, you know, the carbon monoxide is like twice or 3 times higher in the blood than the regular oxygen level. All right, so you want to go ahead and give your high flow to help with getting that out of the patient's body. So high carboxyhemoglobin levels indicate carbon monoxide poisoning, with symptoms like headache, confusion, and lethargy appearing at progressively higher levels, leading to coma and death in severe cases. All right. So diagnosis involves a blood testing or blood test using the CO2 oximeter, and treatment centers on administering high flow oxygen and sometimes putting them in the hyperbaric oxygen therapy to displace CO2 and restore oxygen transport. All right, so that's the whole point of putting them on the high flow oxygen, to kind of help with push out those, the CO2, not the CO2, the carbon monoxide, and get back your oxygen, your rich oxygen back in the system. All right, so that is what you're doing with your oxygen. So anytime you have a patient that comes in and you hear that they've been a part of, a house that was burning down, that's what is, priority for you at that time. Just get them on some high flow oxygen and you're good to go. All right, but also looking at them nose. You understand? Looking at them nose. You understand? Because sometimes it can be cinch, and make sure you're listening to the patients, hearing if there's any change in their voice. Because once you hear the change in their voice, they start becoming hoarse, or they tell you that, oh, nurse are sounding a little bit hoarse. Definitely get that patient into a bed and get that patient prepped for intubation. All right. Because of the edema that is going on there. Fire. Welcome. Thank you so much for tuning in. All right. So Kerry was saying give bicarbonate. I don't think at this stage, Kerry. I don't think at this stage, based on what we were looking at. I think eventually, depending on, the acid-base balance that is going on with the burn patient, then you can think about it, but not for now. All right, not for now. All right, so hoarseness and facial burns is usually indicating airway swelling risk, and that should be, addressed immediately. The patient is definitely going to need a high dose of pain medication as well. All right, applying high flow oxygen is something that you'll definitely be giving this patient as well, via your, when you get the patient on the ventilator. Starting IV fluids is also going to be very, very important for this patient. And when it comes on to burn patient, what is the best practice in terms of the fluids? What fluids will you be grabbing? If you're supposed to choose between dextrose water, lactated ringers, or normal saline, which of the fluids will you be going to get for this patient based on, standard of practice? Kerry says normal saline. I hope you're doing amazing. Thank you. I am, as is. How are you doing? What's the standard of practice when it comes on to your burn patients and IV fluids? What fluids are we getting for these patients? Your lactated ringers. All right, so definitely getting your lactated ringers, Kerry, for this patient. All right. That is on burn. That is a burn patient. So it's a standard fluid for initial burn resuscitation because it closely mimics the fluid loss during a burn injury and helps with expanding intravascular volume, improving tissue perfusion, and provide metabolic fuel through lactate. All right. So that's the reason why they're using the lactated ringers and not the, your isotonic fluids, like your normal saline and all. All right. So always remember, for your burn patient, always grab your lactated ringers, and then, for your other patients, nothing is wrong with getting your normal saline. All right, no problem, as is. Thank you for doing that. Thank you for doing that. Oh, guys, if you haven't subscribed us yet, go ahead and subscribe to my YouTube page when you get a chance. Write down the name. It's ThinkNursing. You can also follow me on TikTok as well. And if you're coming on late, the entire live will be on YouTube, so you can go over there and watch the, the live streams that we do weekly in its entirety as well. All right, and you can always inbox me and I will answer your questions or your concerns. All right. All right. Let's get the live tap up a little bit more. All right, I'm going to be very needy today. So can we get the live tap up to like, just 7,000? It's not that far, just 400 more likes. So let's just exercise this little finger here. If I was on the live, I'll probably exercise it by now, but can't tap up my own live. So definitely let's go ahead and tap up the live. It only says that, we are here up and running and we need more company over here. That's all the live is doing. Sending it out to other persons who are interested. Aziz, are you? Oh, no, Aziz. No. I'm not. All right. All right. Thank you so much. Polly's Kitchen, thank you so much for... How many persons are actually enjoying the live? I probably should have asked that from before. If you're enjoying the live, just put a little heart, whatever color you want to do in terms of the heart. Just drop one in the comment section so we can know that, I'm not talking vain. As it says, okay, thumbs up, okay. All right, just drop a little comment with a heart just to say that the live is going good. Thank you, Carrie, for doing that. Champagne for liking up the live. All right. I see 15 persons on TikTok here. Not even one heart? Not even one? Ryan Simpson, thank you so much for tuning in. No, sir. Why are we behaving like this tonight? Thank you, Claudia. Thank you so much. You give me 5 hearts. All right. Sanja, thank you so much. Thank you for liking up the live. All right. All right. So we're at 7,000. Nice. Thank you so much, guys, for doing that. All right. So let's go on to... Okay, we did talk about albuterol. So let's go on to pulmonary hypertension. Which finding indicates pulmonary hypertension is worsening? So you have a patient that has pulmonary hypertension. How are you gonna know that their symptoms or their condition is worsening? A, peripheral edema. B, clubbing of the fingers. C, dyspnea with exertion. Or D, loud second heart sound. So which finding indicates pulmonary hypertension is worsening? Peripheral edema. B, clubbing of the fingers. C, dyspnea with exertion. Or D, loud second heart sound. D, loud second heart sound. Carrie says C, dyspnea with exertion. Okay. And hypertension, yeah. Sasha Grace, welcome. Claudia says C, dyspnea with hypertension. Okay. All right. So a few persons says C, dyspnea with hypertension, and one person says D, loud second heart sound. So if you have a patient that has pulmonary hypertension, are you concerned about peripheral edema for this patient? And if we're thinking about, just close your eyes and just think about like the pathophysiology behind the condition. That will kind of help you with, some of the questions as well. All right, and choosing the best answer. Because if you have a second heart sound, if you have a second heart sound, a loud second heart sound. So you have your S1, your S2. Sometimes you might have S3, you might have your S4, all right? Does that really say that, a patient pulmonary hypertension is getting worse? All right. So just look at that. The patient has dyspnea with exertion. I can be overweight and I probably just get up out of the bed sitting on the side here so I can't catch my breath. You understand? Does that say that, I'm getting worse? You can have a patient who is a COPD, who is baseline, the SAT is 88%. The patient walks, 2 miles. The patient is short of breath. You have a patient walk to the back of the yard. Them still short of breath because they're still having that dyspnea whenever they do anything. They're lifting something. Does that really say that there's, their condition or their pulmonary hypertension or their COPD is getting worse? All right, how old is the patient? It didn't give an age on the patient. It just says which finding indicates pulmonary hypertension is getting worse. Thank you for the gift, Sasha. All right. Clubbing of the fingers, usually sometimes you'll have clubbing of the fingers, like, you know, for your lung patients that have chronic lung condition. All right, your peripheral edema, that is there, but sometimes if you have a patient that has pulmonary hypertension, and if you understand pulmonary edema and you're trying to link it with any condition, what are you thinking about? If a patient that is hypertensive and the patient is having, you know, peripheral edema, the patient is having edema, swelling in the lower extremity, what is going on for that patient? Because the clubbing of the fingers, that's something that is chronic. Dyspnea with exertion, you know, it varies. Because you can have, as it varies. It can be acute, it can be chronic. All right. But does that really say it is something that is worse, very concerning for a patient with pulmonary hypertension? The low second heart zone, I wouldn't even really worry about that. But when you think about a patient with peripheral edema, what is going on? Yes, clubbing is from the chronic hypoxia. So when you have a patient that has peripheral edema, you're thinking about your CHFs, all right? All right, you're thinking about your CHFR, and you're thinking about the fact that is it right-sided or left-sided? So if the patient has peripheral edema, you're thinking about which side of the, you know, which side heart failure are you thinking about? You're thinking about right-sided. And if you have the patient having pulmonary hypertension, you know, going on, the heart is failing, right side. Right side. So the patient is having the pulmonary hypertension. So everything is backed up in the system. All right. So you're going to have the patient having, like, you know, the pulmonary congestion, all of those things going on. All right. No, not the pulmonary. So the patient is going to have the peripheral edema, the abdomen is going to be swollen, things like those. Because if the right side of the heart is failing, that means that the left lungs, nothing is going past the left lungs, right? So when you have the left-sided, so right side is going to be your pulmonary, your systemic. Your right side is going to be backed up. So the left side is going to be with your pulmonary congestion, your coughing, crackles, and all. Let's pull that up. Not confuse me, no. Boy. All right, right-sided. Distended jugular vein and all. Right-sided, yeah. Right-sided heart failure. All right, so for your right-sided heart failure, you're going to have... your right-sided heart failure, you're going to have your peripheral edema. So we were on the right track. You're going to have your edema, your enlarged liver, because it's going to be in your tummy as well. Ascites, peripheral venous pressure being increased, fatigue, okay, weight gain. When it is the left side, you have the pulmonary congestion, such as your cough, your crackles, all of those things. All right. When you're having your left-sided. All right. So with the left-sided, you have more of the lungs being involved. And with the right-sided, it's more the systemic. So you have your lower extremities and all being swollen. Abdominal distension, jugular vein distension, things like those. All right. So we're on the correct path until I see somebody put right side, left. All right, so for this patient, which finding indicates pulmonary hypertension is worsening? All right, the answer is going to be A, the peripheral edema. All right, the right-sided heart failure from pulmonary hypertension is leading to congestion. It's leading to your edema as well. All right, so clubbing of the finger is going to be something chronic. Dyspnea with exertion can be chronic acute as well, but it might not be something that that is gonna be something that is it can be acute and it can be chronic. All right, and loud second heart zone, as I say, you have your S1, S2, S3, and those are sometimes normal depending on the age group and the conditions that you have. All right, you might have your S3 in your, you know, your hypertension, your pulmonary edema, things like that, your S4, but it doesn't necessarily always indicate that it is getting worse. All right, you can be stable and still have your S3 and your S4 functioning okay. But if you have your peripheral edema, you're thinking about something else going on. Your system is failing. So you're going to be having all of those symptoms. All right. Hi, Lou, Cypher. I'm just going to call you Lou. All right. We're doing NCLEX questions here. I am a nurse. All right. Thank you so much for tuning in and for sharing. All right, so the answer is the right-sided heart failure from the pulmonary hypertension, which leads to the systemic congestion and the edema. All right. And thank you for the follow, Sasha Grace. All right. So you have a patient that is, you're going to be doing tracheostomy care. All right. Tracheostomy wasn't my thing I know how to do it, but it wasn't my favorite in Jamaica. Yeah, because we never normally have like a respiratory therapist or anything, you can always call in the event that something goes wrong. So it wasn't my favorite thing in Jamaica, but yeah. So during tracheostomy suctioning, the patient's heart rate drops from 88 to 50. Why is that? Like trach or Ida, Sasha. Hi, Angela. So why, if you have a patient that you're suctioning and you realize that the patient's heart rate dropped from 88 from a normal and the patient has slowed down, becoming bradycardic at 50, what are you thinking about? Why is that happening? Why the patient brady down? Huh? Okay, so decreased oxygenation. So basically the patient, why the patient is now bradycardic? Suction too long. Well, sometimes when you suction too long, we're talking about the heart rate, not the oxygen saturation. We're thinking about the heart rate. So you suction too long, you tend to cause a drop in your oxygen level. So not necessarily the heart rate. You have a drop in your oxygen level. Probably the heart rate would go up, sometimes depending on if anxiety or something going on. I don't know. Other reasons. But if you're suctioning a patient and you realize that, your heart rate has dropped, yes, the vagal stimulation, yes. All right, you're touching on that vagus nerve there. So usually, just like when you're telling to bear down and do all of those things, yeah, you're suctioning too much and you touched on the wrong nerve. You got some vagus stimulation going on, and the patient will tend to have that low or drop in the heart rate. All right, so just go ahead and stop suction for that time. All right. So the patient will become bradycardic during suctioning because of the vagal stimulation. So you go ahead and just stop and then you reassess the patient. All right. Usually once you stop stimulating, then it will increase. Their heart rate will go back up. All right. So during trach suctioning, the patient's heart rate drops from 88 to 50. What should the nurse do first? So this is the answers we have here. A, stop suctioning immediately. B, administer atropine. C, call the provider. Or D, increase suction pressure. So what would you do here? So you have a patient that you're suctioning and the patient brought it down from 88 to 50. What should the nurse do first? A, stop suctioning immediately. B, administer atropine. C, call the provider. D, increase suction pressure. Definitely A. Stop suctioning immediately, because as we say, the patient is bradying or responding to the mere fact that you're stimulating their vagus nerve. All right. So what if when you stop and you realize that 15 minutes later, the patient's still brady, but the patient is going further down. So the patient is not at 50 anymore, but the patient is at 45. Or let's say 40. Let's get it complicated. The patient's heart rate is at 40. No, what would you be doing? So you realize that, the patient, you call the healthcare provider, definitely, okay, definitely. So anything else you'll be doing for this patient, you realize that, the patient this was a patient that has been like, walking around on the floor, and patient had a trach, so it was time for the patient to come and get the trach done, the trachea done. So you're there and you realize now that, oh, yeah, this patient is ready and done. What else can you be doing in the meantime while the doctor is, you're trying to get in contact with the doctor, or somebody's trying to get in contact with the doctor? What are some other things you can do? You get the patient on the cardiac monitor. Anything else? You get your EKG, definitely. Sit them up in a high Fowler's position. Why in high Fowler's position though, Sasha? So you have this patient bradying down. Why you don't get them in high Fowler's position? So the patient's heart rate is at the 40s, 30s now, Why would you get them in the high Fowler's position? Yes, you can raise the arms. Yes. Would you really get them in the high Fowler position though? Or which position would be better suitable for this one? Raise their heart rate. So the arm would, getting their arm above their head will try to help with that. But getting them in an upright position like this, if they're already bradycardic, would a position like this help them? No, it's not going to help them. So you want to put them in a high Fowler's position. Probably you could put them in the Trendelenburg position, reverse, the opposite. Okay. All right. Need to promote venous return. So you could actually do anything that is going to help with getting back, blood flow to the brain, to the heart, things like that, and help with that heart rate. All right. And what is atropine? Why would you give this patient Trendelenburg? Yes. What is atropine used for? What is atropine used for? Increase the heart rate, definitely. All right, so definitely you'll do that. You'll stop your suctioning immediately. Observe the patient. You can always do things to modify. You can always modify what is going on. The patient is in an upright position because you're cleaning their trach. They start becoming brady. Drop their head off the bed down, lift their legs, things like those to help with getting their heart rate, especially if they start becoming symptomatic. All right, get them on the monitor, get your EKG going. You let your providers, be aware of what's going on. And then from there, make sure them have a good IV working with. All right. So if you realize that there was a little IV down here, that not going to work. All right. So while you're calling the doctor and somebody else calling the doctor for you, work on getting a decent IV for that patient. All right. Especially, as I say, if a patient is becoming so bradycardic or symptomatic. All right. Increasing the suction pressure. I know somebody had said increase the suction pressure. Increasing the suction pressure is going to cause that patient, it's going to worsen the situation for the patient. All right. Because depending on how, at what pressure you were suctioning, and the patient has dropped from 80 to 50, probably that patient would have tumbled out of that chair or out of that bed, if you increase the suction pressure. So no, you will not increase the suction pressure. You just cut off the suctioning completely, stop it completely, and then, just observe the patient. All right. And then from there. All right. So which intervention is most important in managing cystic fibrosis? What do we know about cystic fibrosis? What do we know about cystic fibrosis? Mad secretions. Okay. All right. So with cystic fibrosis, you tend to have a lot of secretion there. Are those patients usually on oxygen all the time, or just sometime when they feel like, what do we know about them? So mad secretions, genetic disorder involving sticky mucus, definitely. So genetic, yes. All right. So a lot of times these patients will have those thick mucus, they're always on oxygen. Sinus problem always kill them, you know, things like those. Wheezing, shortness of breath with the patients there. So which intervention is most important in managing a patient with cystic fibrosis? A, restricting fluids. B, daily chest physiotherapy. C, low-fat diet. D, bed rest during exacerbation. All right. So which intervention is most important in managing this patient with cystic fibrosis? B, daily chest physiotherapy. C, low-fat diet. D, bed rest during exacerbation. Or A, restricting fluids. Kerry says B, Ash B, Sasha B. Okay. And Melissa B. All right, so daily chest physiotherapy. What is it the chest physiotherapy gonna do for this patient? So you tell me that this patient is always gonna be on oxygen and you concerned about beating out the person's chest? Why? Why you wanna go ahead and be like, you know, knocking on this patient's chest every day? That is gonna be annoying. You guys are cruel. Why you wanna do that? Release the mucus. Yes, you wanna loosen up that mucus, and that is the best way to do it. All right. Help with getting some of those secretions, either cough up, sneeze out, whatever way it can come out of the body, then definitely you want to do that. So get your chest physiotherapy going every day for this patient is going to be like the paramount when it comes on to, you know, your physiotherapy with your cystic fibrosis. All right. Which symptom in a patient with lung cancer requires immediate intervention? Is it A, hoarseness, B, bloodstreak sputum, C, superior vena cava syndrome, or D, chronic cough? So you have a patient that has lung cancer. Which one requires immediate intervention? Is it A, hoarseness, B, bloodstreak sputum, C, superior vena cava syndrome, or D, chronic cough? Yes, you want to make sure you give fluids as well, Melissa. That's for the cystic fibrosis patient. All right. So usually warm fluids. You don't want to encourage them to be drinking a lot of fluids to help with that secretion as well. All right. Thanks. So A. So which symptom in a patient with a lung cancer requires immediate intervention? A, hoarseness. B, bloodstreak sputum. C, superior vena cava syndrome. Or D, chronic cough. So we have C. Sasha says C, superior vena cava. B, Carousel says C. Melissa B, A. All right, so yeah, the answer is C, the superior vena cava syndrome. Usually they have like facial swelling, distended neck vein, things like that. That is concern for your oncology patient. And then if you don't really know much about cancer patient or any other questions, sometimes you're probably not familiar with the question, always look at some of the answers and see if it really, is it something that you would really worry about? You understand? Somebody having a chronic cough, like, yeah, we worry about the cough, but are you really worried about that cough? Me? No. All right. Hoarseness, it depends on what's going on. As I say, it depends on the situation, because if it's a patient that has been exposed to smoke, you understand, the patient has inhaled, you know, that smoke, is a burn victim, things like that, then the cough, you know, the hoarseness is okay. Not okay, my bad, take it back. The hoarseness is not okay. We're going to be concerned about the hoarseness because we're thinking about intubating that patient. All right. So for the burn patient, hoarseness is a no-no. You don't want to hear that your burn patient is having hoarseness. All right. So depending on the scenario that they give you, then from there. But if you have a lung patient, a lung cancer patient, and the patient is having hoarseness, is that something that you're really concerned about? Nah. All right. Bloodstreak sputum, it's the same thing. Just think of it. This patient has a cancer and the lung is already, you know, damaged. It's eaten out. Let's just say. You understand? Are you really concerned that much about, you know, blood streak? No. I can cough up and there's some blood streak there. Are you concerned about that? No. You understand? Superior vena cava syndrome. That is the one that is related to the heart. And even if we don't really know much about it, you would probably choose that one. You understand? Because if you hear about it, and most of the time, you know, even though you're a student, you probably read about it and you're thinking about the vena cava, you're thinking about one of those main arteries in the heart. You understand? So definitely if you see that answer, there's a high possibility that you might choose it. So look at the answers, look at the question and see, and then use the process of elimination and see whether or not you would worry about this or not for the answer if you're not familiar with the question. All right. So superior vena cava syndrome is an oncology emergency. So, you know, that's the one that is the answer. All right. And thank you guys for tuning in. If you haven't subscribed as yet, remember subscribe to my YouTube page at ThinkNursing and follow me here on TikTok as well. And in the event that you're just joining, the full live is going to be on YouTube, so you can always check that out as well. All right. Just remember to tap up the live. That's all I'm asking. Tap, share, and comment. Make sure you save your patient. So we need an answer. All right. All right. So you have a patient that is asthmatic. All right. Which medication should the nurse question for your patient? So doctor says, okay, we're going to give these patient these medication, but the one that has asthma, you're going to give albuterol, A, B, Montelukast, C, atenolol, and D, fluticasone. Which one would you question? So which medication should the nurse question for a patient who is asthmatic? A, albuterol, B, Montelukast, C, atenolol, or D, fluticasone. Which one would you question? Which one would you go to the doctor and say, doc, but this don't seem right? Or why not change this one? All right, so Robbie says C. Anybody on YouTube here? Hi, Sunand. Hello to you too. Atenolol. Why are you guys concerned about the atenolol? What atenolol do to know? Why are you concerned about atenolol? What class of drug is atenolol? So it's for hypertension. Not only hypertension, but yeah, can be used for your hypertensive. Sorry, my word, that one. Beta blocker. All right, so we're getting somewhere. So it's a beta blocker. And what we know about beta blockers and asthma. What beta blocker does. Narrows the airway. Yes, it causes vasoconstriction. So this patient is already an asthma patient, is an asthmatic. So you have vasoconstriction going on. So you don't want to give anything that is going to help with that vasoconstriction, because it's just going to be worsening the situation for the patient. What if this patient was a diabetic patient? What would you be concerned about with the beta blocker? So the doctor say, okay, then we're going to give the atenolol. The patient is an asthma. The patient is a diabetic patient. The patient is also hypertensive. So we're going to be giving, you know, the atenolol. We're going to be giving nitroglycerin. We're going to be giving albuterol and the fluticasone. Why would you be concerned about your atenolol for your diabetic patient? Robbie says mixed hyperglycemia. Okay, so you have to look out for these patients because their glucose, is it going to be high or low? So for your diabetic patients, if they are given the atenolol, okay, it's gonna be low. It's a beta blocker, so it's gonna be low. All right, so it's gonna be working and preventing glucagon from being released. So you're gonna have your glucose level eventually gonna be dropping. All right, so you have to go ahead and make sure you're watching those patients with those beta blockers. All right, so it's going to mask the symptoms. It's going to cause them to be hypoglycemic. They're going to become hypoglycemic. All right, so definitely. All right, so beta blockers are going to cause your bronchoconstriction. So you have your bronchoconstriction, your bradycardic, you're gonna have your hypoglycemia. Those are things that, you know, causes, those are side effects of your beta blockers. All right. So you have a nurse. So a nurse is suctioning a trach, a patient with trach. All right. You have a patient that is, a nurse is suctioning a patient with trach. How long should each suction last? All right. So you're suctioning a patient. How long will you be keeping that, you know, suctioning in progress with the patient? All right. Is it A, 5 to 10 seconds? B, 15 to 20 seconds? C, 25 to 30 seconds? Or D, as long as needed to clear out the secretion? So if you have this patient and you're suctioning, what is the recommended time period for you to stay there in terms of with that, you know, suction pass? Is it 5 to 10 seconds? A, B, 15 to 20 seconds, C, 25 to 30 seconds, or D, as long as you feel like. Tamara says A, Kerry says A, Robbie, okay, 5 to 10 seconds. All right, so no more than 10 seconds is what is recommended when you're doing your suctioning. All right, and why you want to, you know, stay under 10 seconds? Why you want to do that? Because what happens when you're suctioning? You don't wanna stay for too long? Avoid dehydration. Well, vagus stimulation, vagus nerve, okay. Nice, nice. And not only that, what about oxygen? What will be happening there as well? Deprive them, yes. So there's so many things that that is happening. So if this patient is on, oxygen, you want to make sure that you go ahead and pre-oxygenate this patient before you suction. All right, make sure you kind of give them a lot of oxygen and then you go ahead and suction. Because remember, just think about that sucking effect. You know, you're rubbing the patient, you're depriving them of their little oxygen that they probably don't have enough of. All right. So make sure you're looking out for that. You're looking at your monitor, your oxygen saturation. So that way, as soon as it starts going down, trending down into those critical numbers, you want to make sure you get back that patient on oxygen so that you're not causing worsening problem for that patient. All right. All right. So suctioning should last no more than 10 seconds to prevent hypoxia, as well as, you drop in your heart rate, things like those. The vagal stimulation that results from suctioning as well. All right. We did one similar to that already. Which is the most effective treatment for severe obstructive sleep apnea? So which is the most effective treatment for your obstructive sleep apnea? A, weight loss. B, avoiding alcohol before bed. C, CPAP at night. And D, positional therapy. Sasha says CPAP. Okay. C, definitely. All right. What we know about CPAP? What we know about CPAP for your obstructive sleep apnea patients? What is it gonna do? Positive pressure. Okay. Blows in oxygen. Okay, yes. Keep the airway open. All right, nice. So the CPAP at night is what is going to help with them. So severe obstructive, so you want to have something that is going to give them positive pressure, oxygen, keep those, airway open while they're sleeping at night. All right. So CPAP is the gold standard for your moderate to severe moderate to severe obstructive sleep apnea. Would weight loss benefit these patients? Would weight loss benefit this patient? Yes, encouraging them to lose a little bit of a weight is not a little bit, a lot of weight is definitely going to help with that. All right, because a lot of times what is happening when you have on too much weight? Like my belly big right now, sometimes I can't hardly breathe, you understand? So things like that, just think of it. If you have too much, excess, if you have an excess, fat, we're not really say the word too much because, but if you have on too much, then it can cause problem with your breathing because you're not allowing for, your airway, your lungs to expand properly. And so, opposite pressure, yes, you're not allowing for your lungs to expand properly. And so that can cause problems with your breathing. And not to mention when you lie down, you understand, if you have 20 pound, 30 pound, 100 pound extra there, then that's going to be a lot of problem with, with your lungs trying to expand. So it's going to feel as though you're always just suffocating. So that's just it. All right. So the weight loss is going to be very, very good. Avoiding alcohol before bed. Avoid alcohol in general. Let's just see. All right. Positional therapy. I guess positional therapy is what? Sleeping position, whichever side you sleep comfortable on, I guess. All right. Which diagnostic test is most specific for PE, pulmonary hypertension? Is it a chest X-ray, B, ABGs, C, D-dimer, or D, CT pulmonary angiogram? So which diagnostic test is most specific for PE? A chest X-ray, B, ABGs, C, a D-dimer, or D, CT pulmonary angiogram? CTPA, okay, angiogram. Someone says, Tamara says D-dimer. Okay, Melissa says D. Definitely your CT angiogram is your gold standard. The D-dimer is going to tell, yes, you have a, it's going to be elevated if you have a clot on board, but it's not going to tell you exactly where. Because if you have a clot in your leg, it's going to be elevated. If you have a clot in your heart, it's going to be elevated. Anywhere that you have a clot, the D-dimer is going to say that it is positive. But if definitely, you want to see if you have a PE, it's always good to go with your CT angiogram. All right, you get that dye in and look in the lungs itself, all right, the chest itself, to see where that that clot is. All right, so sometimes you might find out that you're probably saying, oh, let's get a D-dimer, let's get a blue top, and the doctor just said, no, we're not gonna do no blue top, we're just gonna get the patient to CT. It's because it would be depending on the patient's symptoms, it might just seem like a total waste of resource to go ahead and get a D-dimer when you know that the patient is showing a lot of signs or having symptoms of a PE, but you just need something to confirm it. A lot of times we do it routine to say, yes, there's a clot on board. But if you already suspect that if there's a high suspicion for a clot, you just get straight to the, the testing that is going to confirm that there is one. So if you're thinking about the DVT and you say, oh yeah, they probably have a clot in their leg, just go ahead and get their Doppler, go ahead and get a CT scan, whatever it is that you need. And then from there, confirm the diagnosis. But if you're just there and you're having a young person come in and they're saying, oh yeah, it sounds like, PE, but we don't really have enough evidence to say, okay, then this patient is a definite, they're just going by the fact that, oh yeah, she is a young person, she's on contraceptive, and she just come in with a little chest pain every now and again. She's not tachycardic, she's not having any chest pain now, but she just feel like she have a PE, because guess what? She didn't have the health feel. So let's just go ahead and go to the emergency room. So the doctor might say, oh yeah, you don't really have enough things to say. Okay, then, definitely, let's just get a blue top. And the blue top might come back negative. Then no need to do the CT scan again. A lot of times they might not do it. You understand? Because if it's not saying that, yeah, you have a clot somewhere because your D-dimer is not elevated, they might not go ahead and do $1 million workup on you. You understand? Because your complaints or your symptoms or your signs are just not enough to say, okay, then it is worth $1 million workup. So that's just it. All right, so your ABGs, who do you normally do your ABGs on? They do VQ scan still. Yes, they do VQ scan. I was working at this heart hospital that does that. Yeah, so they do it, not an emergency. They don't do it as an emergency, but they still do VQ scan. All right. And as usual, it is going to be depending on what is going on with the patient. Then you might find 1 or 2 providers. Just go ahead and do it. All right, chest X-ray. Almost everybody gets chest X-ray. All right, chest X-ray is almost like Tylenol. Tylenol, you have chest pain. Oh yeah, let's get a chest x-ray, you know. So that's just it. All right. ABGs, a lot of times you might find out that you have your patients in ICU, a lot of times will get your ABGs. Sometimes you will have your diabetic patients, your DKA patients be getting ABGs, things like those. All right. Your critically ill patients in general will be getting your ABGs. All right. All right. Which assessment is expected in a patient with chronic bronchitis? So I have a patient that has chronic bronchitis. And which assessment is expected in that patient? All right. A, barrel chest. B, dry hacking cough. C, large amounts of thick sputum. Or D, severe weight loss. So you have a patient that is having chronic bronchitis. What is an assessment finding for this patient? Is it A, barrel chest, B, dry hacking cough, C, large amounts of thick sputum, D, severe weight loss? So I see CAC, so large amounts of thick sputum, barrel chest. Let's see, one person says B, dry hacking cough. Tamara says C, carry A. All right, so what we know about chronic bronchitis, they have a lot of sputum. All right, so they tend to have the chronic cough, the large amount of sputum, they'll tend to have that. So the large amounts of thick sputum is 8. Dry hacking cough, will their cough be dry? What's it B? Did anyone say B? Dry? So usually it's going to be wet. All right, so they'll be having that cough. The dry hacking cough is, the answer again. The answer is C. So A is barrel chest. B is dry hacking cough. C is large amounts of thick sputum. Or D, severe weight loss. And this is the assessment that you're expecting in a patient with chronic asthma, chronic bronchitis. Okay, you're fine. All right, so the answer is C. So patient with chronic bronchitis tend to have a productive cough. They tend to be having large sputum. These are the ones that they call the blue bloater. All right, so let's look that up. All right. Who normally has the barrel chest? Who normally have the barrel chest? Your COPDs, yes. Your COPDs, emphysema, your asthma patient, yes. All of those persons, cystic fibrosis tend to have that as well. What was the other answer they have? Okay. All right. So, but the assessment is expected with, and then severe weight loss, can go either way, but sometimes they tend to have weight loss as well. But if you were supposed to choose from this, because you have the barrel chest here, all right, which assessment is expected in patient with chronic bronchitis? So barrel chest is one of them, and you also have the large amounts of thick sputum. Out of those two, which of them would you choose for the patient with chronic bronchitis? So barrel chest is pretty good with your COPDs, your emphysema, the sputum. Okay. All right, because I know someone had chosen barrel chest earlier, so I wanted to find out of the two answers. So always try to use the process of elimination, and then always try to use your pathophysiology, the disease process itself, mechanism of action. Just look at it and see, okay then, if I get this question, which answer would be best suitable for this specific question? So use the process of elimination to start as well. And then from there, you narrow it down to, okay, then if it is a case like, with patients with COPD, have barrel chest emphysema, all of those things. But if there is one that, you can, if there's another answer that is more specific to, say, for example, if they're talking about the signs and symptoms, things like those, then you can always use that to help with your answer. All right. So the chronic bronchitis, productive cough with large sputum, blue bloater, symptoms. Oh, I was looking up the blue bloater. Let me look up that. All right, so you have the blue bloater versus the pink puffer. All right, so your chronic bronchitis patients are your blue bloaters, and your pink puffers are your emphysema. All right, so okay, so with your chronic bronchitis, you have the chronic productive cough, purulent sputum, hemoptysis, mild dyspnea, cyanosis, crackles. And then with your emphysema, which is a pink puffer, you have the dyspnea, minimal cough, increased minute, ventilation, pink skin, pursed lip breathing, accessory muscle. Okay, so with the emphysema, you have the hyperinflation and the barrel chest. Why they call it pink, why they call it the pink skin versus the blue skin? So why is it the pink skin versus the blue skin? Why the emphysema has the pink skin and the chronic bronchitis is known as the blue bloater? Why? So with the pink puffers, the emphysema, their lungs have become destroyed. All right. So they have destroyed air sacs, causing them to be thin, hyperventilate with pursed lip, breathe rapidly, and appear pink due to adequate oxygenation, but difficulty exhaling. All right. So that's why they're pink. So they appear pink because they have adequate oxygen, but they have a big problem with exhaling. So that's why they're always like puffing. You understand? And then with your blue bloaters, who are your chronic bronchitis, which is a type of your COPD, that patient has excess mucus production. They have the chronic cough, low oxygen levels leading to a bluish skin tone, and they have a tendency to be overweight. All right. So with the emphysema, just think of it that they have, their sacs are actually destroyed. So they're thin. They have a lot of oxygen on board. So when you check their oxygen, it's going to be probably normal. All right. The numbers are going to be good because they have a lot of oxygen there, but they're puffing. They're having a hard time releasing. All right. Exhaling that. And then with the COPD, the bronchitis, they have low oxygen levels. So that's why they are cyanotic. All right. So that's one way to look at it. Okay. All right. Oh, I'm going to do 2 more questions and then I'm done. I didn't even realize it was 9:30. Probably that's why Cara said I sleep off, so. All right. Let me talk about that one. Not gonna do that one. All right. So I'm gonna do this one. So which patient is at risk for aspiration pneumonia? Which patient is at risk for aspiration pneumonia? Is it a 40-year-old with asthma using albuterol? Is it a 65-year-old post-stroke with a dysphagia?
Mommy.
Sorry.
Mommy, you said tomorrow I'm going to get a gift?
Yes. So he got all his words correct today. So I said that I was going to give him a gift. So that's what he's getting out of bed, trying to find out if tomorrow he's getting a gift.
And I'm going to get something very good.
Okay. It's bedtime though.
Mm-hmm.
All right. So Sorry about that. So which patient is at greatest risk for aspiration pneumonia? A, 40-year-old with asthma using inhaler, the albuterol. B, the 65-year-old with a post-stroke with dysphagia. C, the 28-year-old with viral bronchitis. Or D, a 50-year-old with sleep apnea on CPAP. So which patient is at greatest risk for aspiration pneumonia? B, the 65-year-old post-stroke with dysphagia. Yes. All right. So what is dysphagia? What's dysphagia? Patient just have stroke. Like, why that one is going to be at risk for? What about the one that is sleeping, difficulty swallowing? Yeah. What about the one that was sleeping? What if somebody decides to, But yeah. The one that has the dysphagia, the 65-year-old post-stroke with dysphagia is going to be at risk for aspiration. So you have impairment with the swallowing, all right? So they're going to always be at risk for that. 50-year-old with the sleep apnea on CPAP. Yeah, the viral bronchitis. Okay. All right. And then let's see. This one. And then the last question, I'm trying to find one last question. But remember to go ahead and tap up the live. All right. Oh, sorry. And the age, yes. Remember to go ahead and tap up the live. All right. Trying to find one question here. Clicks. All right, this one is. All right, this one is not a This one is not a respiratory, so we're gonna just hit us with a very hard one. A very. I made a correction by the a tablet. All right, so you have a patient with ABG results of a pH of 7.25. All right, so the pH is 7.25. PaCO2 is 60. The bicarb, which is the HCO3, is 25. What is your interpretation of that ABG? So you have the pH of 7.25. The PaCO2 is 60. And then you have the HCO3 is 25. What is your answer for that one? So Sasha says acidosis. Okay. Carousel says respiratory acidosis. Melissa says respiratory acidosis, respiratory acidosis. Everybody say acidosis. Okay. Yes. All right. So what's a normal pH? What's a normal level for pH? Seven point 7.35 to 7.45. And what's the normal for your CO2? $35 to $45. 35 to 45, yes. Your bicarb, I think Sasha, you're mixing up the bicarb and the CO2. Okay, so no, yes, the 22 to 26. All right. So based on what we have here, 7.25 is acidic. Your CO2 is your respiratory. All right. Is the bicarb normal? The HCO3, that's normal. All right. So basically, you don't really have anything going on there for that one. So this patient is in respiratory acidosis. All right. Because the bicarbonate is normal. So when you have a low pH and you have a high CO2, usually you'll be in respiratory acidosis. So if you have a patient in metabolic, let's see. If you have a patient that is going to be in metabolic alkalosis, what would be your, if you have a patient that is in metabolic alkalosis, what would be your, the direction for your CO2, your bicarb, and your pH? What's the alkalosis? pH will be high. Okay. pH is going to be greater than 7.45. pH, high pH and metabolic is going to be high. Okay. And what is going to happen with the bicarb? No, yeah, what is the bicarb, pH and bicarb high, pH metabolic. Bicarbonate is going to be low. CO2 is going to be normal. Yeah, so that's the one I had missed out. CO2 is normal. Okay. So if you have, so the pH is going to be greater. So if you have a patient that has metabolic alkalosis, you're going to have the pH that is going to be like around 7.45 or greater. The CO2 is going to be the high, 45, 48 thereabout. Bicarb probably around 36, you know, that area there. All right. So, let me look at this question. So a patient with a history of prolonged vomiting, the patient is on loop diuretic use, and the patient presents with muscle cramps, confusion, and shallow respirations. Your ABG shows your pH of 7.5, your PaCO2 of 48, your bicarb is 36. All right. So this patient is in metabolic alkalosis. Which intervention should the nurse first implement? Yes, the patient is in metabolic alkalosis. Which intervention should the nurse first implement? A, administer sodium bicarb. B, encourage the patient to take deep breaths, slow breaths. C, replace the potassium as prescribed. Or D, prepare for intubation. So C, B, okay. So replacing the potassium, yeah. Because a lot of times when you think about metabolic alkalosis, you have patients losing. So usually patients will be losing. So like your diarrhea, your vomiting, the patients that are on your loop diuretics, all of those puts your patient in a metabolic alkalosis state. All right. So always go ahead and replace the potassium, and then from there. So prolonged vomiting, diuretics used tend to lose, you know, you lose your hydrogen, your ions, your potassium, and so it puts you at alkalosis. So always go ahead and correct those. If your patient is having if your diabetic patients are at risk for what? Not you, Carousel, not you, Melissa. So you're having diabetic patients, your patients in DKA, they're most of the time at risk for what ABG imbalance? So they're at risk for hypoglycemia, but in terms of ABG, ketoacidosis, All right, so are they gonna be in like, you know, respiratory? Are they gonna be in metabolic, acidosis, alkalosis, acidosis, metabolic? Yes, they're gonna be in metabolic acidosis. Yes, okay. All right. I'm gonna do a live where we can do metabolic acidosis. Yes. All right, so we'll do one live where we can go through a few questions regarding, like, you know, your metabolic acidosis, things like those, and then from there. All right, but definitely. All right, so always, you know, once you know the normal values for your AB, Gs, you know, then usually that will help with your, you know, you understanding which you know, which direction or what's the diagnosis in terms of your metabolic alkalosis and all, like which direction they're at. All right, so we can do that, and then from there, RENR. Yes, how is it helping though, Melissa? Because as I say, it should help with any one of the exams we're doing, whether or not you're doing your RENR for the regional, like, you know, the Caribbean, or if you're doing the NCLEX, it should help because it's more like, you know, general information for nurses, you know, so not a problem, Sasha. Well, definitely join us on Thursday. You understand? Join us on Thursday for more questions. What I'm trying to do is do them like, you know, system. Try to see if I can do them by system, and then we can always go and do different conditions as we go along. But I'm up for suggestions in terms of what, you know, what area you want me to prep some questions for, and then we can come and just discuss, you know, the questions and answer them together. Not a problem. Thank you so much, Dorian, as usual, for always coming on. So I'll be online at 7 again. We'll be online at 7 on Thursday. So on Tuesdays and Thursdays, we'll do the NCLEX questions, or, you know, quick practice questions every Tuesday and Thursday. Carrie said yes. So we're trying to be consistent with every Tuesday and Thursday for the NCLEX questions at 7 p.m. I'm streaming on YouTube and I'm streaming on TikTok as well at that time. So definitely, if you miss it, then you can always get the full length of the live on YouTube at ThinkNursing. All right, so go over there and subscribe to the page. I also did cardiovascular. We did a ton of cardiovascular questions and not respiratory, and GI questions as well. For the last 2 live, that's how we were doing them. So you can always go over there and, you know, just listen to some of the questions, and then from there. Oh, no, not Jamaica time. EST time. So my time right now is 9:47 p.m. So I know by next week or so next month, when the time I go change, so that I go drop back 1 hour. But I will definitely try to make sure I post it. I'm also scheduling it on the live, on the page, on my TikTok. Yeah, the calendar. So I'll definitely put it there so you guys can be aware. All right. But thank you so much for tuning in and for making it so fun. Yeah, it was really good. I really enjoy myself, and I'm learning as I go along. Because as I say, you're never too old to learn, you know. You're never too old to learn, whether or not in age or in your nursing career or your career in general. You're never too old to learn. So it has been something that has been good. It's a refresher for me as well. So, you know, thank you guys for keeping me up. Not a problem, Melissa. Carousel, good night to you too. Sasha. All right, enjoy your night, and I'll see you next week. I'll still do pop-up in between, so if you have questions, you can always ask during the week at 7. All right, but it was nice having you guys here today. All right. All righty, so bye. All right, no problem, Tamara. Remember to go ahead and subscribe. Kerry, it was nice seeing you. Well, yeah, man, no problem, Melissa. You coming in the morning? Not a problem. Thank you so much, Robbie, for that. I really appreciate you. Yeah. So tomorrow morning I'll be doing my Peloton ride at 7. Not at 7, 5:30 in the morning. So I have to go on my bed, go lie down and sleep, so we can actually get back up and do my little ride. Yeah. In the evening. Oh yeah, I'll definitely be on tomorrow. All right then. Well, family, it was nice seeing you again. All right. Yeah, man, Kerry. Later.